Hello to everyone. Please join in. Hello to everyone. Hello, 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 hello. Join in. Please join in. We are starting the class. Class has started. Please join in. Yeah, we are starting. Sorry for coming late. Actually, I was stuck in that old session, so I just came here now. Please join in. We have started the session. So today we are doing what? Surgery last part. Tomorrow we'll do OBG. Tomorrow will be OBG. So let's start with today's session. We'll be doing the remaining part of this breast cancers. Okay. Okay. Some topic we have merged with patho like achalasia and the GIT topics we'll do in the patho, not here. So that's why we're doing mostly the important ones which are important surgery point of view. Okay. Clear? So yeah, kidney is there. Okay. Yeah, pancreas, GB, I'll discuss in medicine also, like Crohn's disease and ulcerative colitis and cirrhosis. So that's why I am doing it integrated with some topic done in patho, some done in medicine. So the ones which are needed only for surgery, which are there. Okay, let's start. So what are the prognostic factors needed for our carcinoma breast? It is the surgery staging, TNM staging, and single most important if they ask you is axillary lymph node status. Very important. And also what is the most important metastatic? It is estrogen progesterone receptor level, that is HR, human estrogen receptor and the progesterone. Okay, so PR receptor. Okay, now there is also Bloom Richardson staging, which is ONM. It's similar to TNM, but it's basically based on the changes in the cell. So there's histological changes, tubule formation, nuclear pleomorphism, that's different in the size and the shape of nuclei, and finally sure, we'll put that J. Okay, after the exam, my center is in Lucknow, so I'll be going to Lucknow, not getting Delhi center. So once I finish the exam, I will do a review of the paper and we'll discuss the questions. Okay, all the questions will be discussed by faculties. I will discuss my share, plus we'll take a session very soon afterwards. Okay, chalo. So let's start. We are discussing sentinel lymph node biopsy. So we are discussing the sentinel lymph node biopsy. Okay, what is the story about the sentinel lymph node biopsy is? So first, it is first lymph node which receive the lymph directly from the tumor cell. It's called a sentinel. That is why we need to sample it, so to know whether metastasis to the lymph node is started or not. Okay, then Cabana first established the concept of sentinel, so that's why it's also called as Cabana procedure. Okay, next question is, okay, this is the case, we inject the dye in the tumor and we check where the dye is present. Okay, so we are putting the dye and then we'll do the probe to take the sample, and then we are able to know which area is getting the tumor cells. Okay, next question, technique is, multiple techniques are there, but I am just skipping that. But mainly if radioactive we use technetium 99, or if blue dye we are putting the lymphazurin. Azurin is again a dye which is giving the blue color. Now most common complication is tattooing. Okay, most common nerve injured is the intercostobrachial nerve, which is in the intercostal space. Okay, chalo. Good evening, Dr. Sagarika. Okay, now I'm just skipping that part, not much. Now very important is inflammatory breast. It is the worst prognosis. And what is that? First, it corresponds to the stage 3B, that is locally advanced breast cancer. So it is stage 3B, locally advanced. Inflammatory changes more than 33%. That's again a very dangerous thing. And there is all the finding of inflammation like erythema, induration, that is swelling, plus there's pure orange. So if there are pure orange, erythema, induration, they all are suggestive of inflammatory. Then we can do even skin biopsy. What do you see? Tumor cells in the lymphatics. That is invasion of the local structures are there. Management is all. We do chemotherapy plus MRM plus radio. That means give all three. All three. Chemo, then radio and MRM. All three given in inflammatory stage is also 3. तो याद करना 3 का 3 है. Inflammatory breast cancer advanced वाला 3B, and the treatment is also all 3. Is the most malignant and worst prognosis. So that's the exam question. Okay. Then first investigation always I told you is ultrasound. Then biopsy is always the diagnostic one. Okay. And remember radiation, this pregnancy. So if pregnancy we are not doing radiation or mammography, then we go for ultrasound and biopsy if pregnant. Okay. Next, if it's a early invasive breast cancer, simple mastectomy can be done. Okay. Plus we can also do what? Yes. So if locally advanced breast cancer, we give all 3, which we discussed already. Then this chemotherapy is given after completion of first trimester, because it can harm the organ development in the fetus. And finally, yes, MRM can be done in the second trimester, because we can't give general anesthesia in first. Okay. And radiotherapy after the treatment. So obviously what we give in the first trimester, we can do the chemotherapy, second trimester MRM, and then तो उसका mnemonic बना लो CMR. Chemotherapy in first trimester and this mastectomy MRM second, and radiotherapy third trimester. Okay. कोई नहीं, live life king size. अभी सोचने से कुछ नहीं होगा. If you think now I'm getting low score, what should I do to increase? It'll just make you get what? Very disappointed. So my advice is ignore all this now and just stop giving GTs and focus on your theory and MCQs. Clear? Subject wise question कर लो, छोड़ दो. कई बार क्या होता है ना, looking at the outcome is not good. Like example, I know I'm not going to get selected for some program. So either I don't give the exam or I give without expectations. Okay. So that's why just focus on, yes, improving your knowledge, study, improve your revisions, do more PYQs. That's it. Now come Paget disease, very important. It's a eczematous eruption of nipple. Okay. And underlying malignancy could be DCIS. Okay. Or invasive ductal cancer. Okay. So in situ, it could be in situ or it could be invasive. Both are possible. Yeah, it's more than sufficient, Molika. Medicine race sessions are one of the easiest medicine session. You can check any other subject. They just discuss MCQs. MCQs, so I will also discuss. But point is, are MCQ only without theory sufficient? No, na? So that's why I will focus on this. MCQs, I will take a very important session of all expected MCQ. Already yesterday, Dr. Puneet Bhojani took the questions of the OBG. Then tomorrow, Dr. Priya Sachdev is taking the session. Then Dr. Aman Sethia. So already we have lined up good faculties for sessions. So you have to just take their sessions. Okay. Chalo. Next question. So Paget disease, okay, versus superficial spreading malignant, both look similar. So this malignant melanoma and the Paget can look similar. So you can differentiate first. Paget disease marker is CA, chorionic embryonic antigen, and for the malignant Sa, it's S100 positive. So it's S100 positive. Okay. Diagnosis: mammography plus biopsy. Okay. And we see Paget cell in the Paget disease of the nipple. Okay. Treatment is simple or total mastectomy. Okay. Phylloids, very important. It's a serocystic disease of the Brody or cystosarcoma phylloids. Phylloid tumor, very big in size, and there are area with cyst, that is there is hemorrhage, necrosis, and cysts are formed. Okay. Most common spread is hematogenous. Remember, carcinoma spread through the lymphatics and sarcoma spread through the blood routes. Okay, that's why it's very malignant and it spread most commonly to the lungs. Okay, lymphatic spread is mainly for carcinomas, and they are also axillary are the one which are very important for deciding the staging plus the prognosis. So what is phylloids? It look like leaf. When you do a cut section, gross and not this appearance, it is leaf like. Phylloids is leaf. Phyllo leaf. Phylloids is leaf like. Loids. Next question, what is not involved? Nipple. Nipple is affected in the Paget disease. Pectoral and breast skin are not involved. Okay. Here we do biopsy, and management is, if it is a benign, we do local wide excision. If it is malignant, simple mastectomy. Simple. And here we are not giving the chemo and this. Okay. Reason, there is no lymphatic drainage. Okay. So that's why MRM is not done. Reason, in MRM we remove the lymph node. Here we don't take the lymph node because it is not spread through lymphatic but rather blood. If it's malignant, we obviously have to remove this. Now this is 100% exam question. Please, all of you watching me, do it properly, and this will be there in the exam. NEET PG also I will also be giving, and the question of NEET PG are asked in the FMG exam. So anyone who's listening me, those who are giving FMG, please don't miss the MCQ discussion session after the NEET PG. That's very, very important. Okay. Okay. Chalo. So let's start. Okay. First is, it is based on gene expression profiling, luminal A, luminal B, normal, breast-like, and basal cell type. These are the four. Now remember, first, what is the triple negative? It is basal cell type. Is triple negative. Clear? Then we have the luminal A. इसमें क्या होगा? आपका डबल पॉजिटिव है. क्या है इसमें? डबल पॉजिटिव. तो याद कर लो, ER/PR, ईस्ट्रोजन रिसेप्टर, प्रोजेस्टेरॉन, एंड इट इज ह्यूमन ईस्ट्रोजन रिसेप्टर 2. So that is negative. So remember, ER/PR is what? Positive, but her is not. ठीक है? तो ये क्या है? इसका और पुस्का पॉजिटिव, बट हर इज. तो ER/PR, ईस्ट्रोजन, प्रोजेस्टेरॉन, ईस्ट्रोजन, सो ईस्ट्रोजन सा पॉजिटिव. सो E एंड P प्लस है पर H नेगेटिव है. तो याद करना EP. इसमें तीनों पॉजिटिव है. दैट इज लुमिनल B. B में क्या होगा? ऑल पॉजिटिव. B इज ऑल. B मतलब सबको इंक्लूड कर लो, ऑल पॉजिटिव. ओके. देन नॉर्मल में क्या होगा? ER, ओनली E. E प्लस. E क्या है आपका? एवरीवेयर, सो इट इज नॉर्मल. E इज एवरीवेयर, नॉर्मल. एंड एवरीथिंग नेगेटिव इज बेसल. सो बेसल क्या है? सब बकवास है. बेसल. सो बेसल बोलता है सब नेगेटिव. तो एक बार याद कर लेते हैं. कैन यू डू दैट विद मी? ओके. ओके. So let's discuss the type, and एक और है HER2 new, which is only positive for HER2, okay, and not for anyone else. Okay, so let's discuss the types. Can you do that with me? Okay, let's do it. चलो, tell me. Luminal A, luminal B, then आपका basal, और एक तो हो गया HER नो ओनली. एक और रह गया नॉर्मल ब्रेस्ट लाइक. हो गया शायद ना? नॉर्मल हो गया. चलो, हो गया. और एक बेजल हो गया. एक ब्रेस्ट लाइक, नॉर्मल ब्रेस्ट लाइक. कैसे करेंगे? लुमिनल ए में क्या होता है? ओनली ईपी पॉजिटिव, ईआर पॉजिटिव, पीआर पॉजिटिव, हर नेगेटिव। लुमिनल बी में ऑल पॉजिटिव। बेजल में बेजल ऑल नेगेटिव। नॉर्मल ब्रेस्ट में ईआर पॉजिटिव एंड इसमें ओनली हर पॉजिटिव। Is it clear? If I make a mistake, do remind me. Is it clear, all of you? या बेजल मतलब बर्बाद, बेजल मतलब क्या? सब बकवास है। क्या बोलता है? बस 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 करो, बस। तो बोलता है बस, बस मतलब सब बंद है। सो बस करो, स्टॉप इट, दैट इज बेजल। ओके, नॉर्मल इज ओनली ईआर, ईस्ट्रोजन एक्ट्स नॉर्मल। ओके, इफ luminal it is ER PR. If luminal B, all positive. Luminal B, all positive, all positive, all positive. Okay. And what about the her only? Her new only. Here only her is positive, nothing else. Only what is positive? Her is the only one which is positive. Only her is positive. Are you clear? Chalo. Let's move on. Now remember what is the best prognosis? Luminal A. Worst is her too new. But some books have given it is also for luminal what's basal side. It is also worse. But if they ask in the exam, it is basically best is luminal A. A हमेशा best होता है, याद करना। जैसे आपके A for apple, apple products are best है ना, और A for आशीष सर है ना, ऐसे। तो A बेस्ट होता है, याद रखना। A इज बेस्ट। ओके, A इज बेस्ट। और ये हर जो सिर्फ अपनी बात करे, जो लड़की सिर्फ बोले आई मी माई सेल्फ, मैं मेरा, दैट इज बैड, वर्स्ट। सो अ गर्ल टॉकिंग ओनली अबाउट हर इज बैड। सो याद करना, हर इज बैड, हर न्यू टू इज बेस्ट, हर इज बेस्ट। सही है। सो इफ अ गर्ल टॉक अबाउट हर, शी इज बैड। एंड हु इज बेस्ट? A इज बेस्ट, A इज बेस्ट, A इज बेस्ट। ओके ओके, चलो लेट्स मूव ऑन। बाकी ये बता चुके हम ऑलरेडी, ब्राका और ये वी हैव डन दैट। मेल में इज ब्राका 2 होता है, फीमेल में ब्राका 1 इज द वन विद हाई रिस्क। ओके, क्रोमोसोम इज 17 फॉर ब्राका एंड इट वाज इन एंजेला जोली आल्सो पॉजिटिव। इट कॉज बायलैटरल इन्वेसिव डक्टल कार्सिनोमा। ओके, वेयर इज मेल्स में इट इज BRCA2। ओके, चलो नाउ फाइब्रोएडेनोमा, वेरी इंपॉर्टेंट, 100 टाइम आस्क। Remember, it is called as breast mouth, is very firm and mobile. So when you're palpating, it keep on shifting. That give the appearance like a mouse. Okay, so it's very benign and seen in young patient. Investigation FNAC and mammography. You see popcorn. Can you see popcorn? So popcorn has what? Irregular margins. So popcorn is like this. So black color के circle भी होते हैं बीच में. This is looking like a popcorn. So popcorn like appearance is seen in which condition? So answer is fibroadenoma. सही है, तो याद करना फाइब्रो, ठीक है, is our yes. Management is basically observation and we can do excision if it's a yes causing problem in size or maybe not looking good or having problem. Okay, then come our string phlebitis. It's a basically thrombophlebitis of the inferior mammillary vein. So you can see the vein is looking yes much more thicker, indurated. That is called as the inflammation of the vein, thrombophlebitis. ठीक है, next question, what is the yes most commonly seen in the lactating female and mainly primary, and they are because of faulty feeding technique. What is their infection is also there, that is staph aureus. So what is the infection by staph aureus? Okay, now what are the other findings? Okay, in the case of breast abscess, so in this case there could be pain, tenderness, erythema, engorgement, increased temperature, fever. They're all suggestive of the yes inflammation, abscess. They were discussing of abscess, breast abscess. Okay, now what we need to do in the case of breast abscess, there is 33% of the breast involvement in inflammatory breast cancer, which you discussed already. But there is no fever or temperature. That is seen in staph aureus, which cause the yes infection because of the pyogens. Okay, now comes management. So incision drainage plus antibiotics and we use basically cloxacillin or dicloxacillin. MCQ. Juska disease. So what is Juska disease? It is recurrent periductal mastitis, okay, and seen in, yes, तो जुस्का, तो याद करना, जो पीती है क्या सिगरेट, जुस्का उसका सिगरेट, तो क्या है जुस्का, जुस्का इज सिगरेट, ओके. सो ये क्या है आपका, जुस्का इज सिगरेट, ओके. सो यू कैन रिमेंबर इफ यू वांट अ निमोनिक, ओके. रशियन गर्ल्स दे स्मोक अ लॉट, ऑलमोस्ट ऑल रशियन. सो देवुष्का, तो रशियन देवुष्का सिगरेट पीती है एंड शी हैज इन्फ्लेमेशन ऑफ हर ब्रेस्ट, ओके, क्लियर. तो अगेन incision and drainage is the treatment. So incision and the drainage, okay. This I am skipping because we have already covered that. So now we discuss the thyroid, okay. First is thyroid, the most important. They ask you with the photo is midline swelling. So there's a midline swelling in the anterior part which move with swallowing or protrusion of tongue like this. This is thyroglossal cyst. Basically it is a congenital anomaly, okay. So what we do in this case is, yes, we will do cyst rub. तो याद करना, सिस्टर को सिस्ट थी, सिस्टर, तो निमोनिक की सिस्टर को सिस्ट थी. So sister had a cyst, cyst. कौन सी, thyroglossal cyst. That's why it become prominent on protrusion of the tongue, move up and down. So it goes up and down, plus also with swallowing, okay, move with swallowing, okay. ओके. नेक्स्ट इज रेट्रोस्टर्नल गोइटर. इसमें आता है बड़ा स्पेशल पेम्बर्टन साइन. सो व्हेन यू रेज द हैंड इट कॉजेस कंप्रेशन ऑफ द venous ड्रेनेज ऑफ द हेड एंड नेक, सो दे बिकम रेड कंजेस्टेड. सो इफ द रेड congested face is seen on raising the arm, it is called as Pemberton sign. What sign? Pemberton sign. What is it called as? Substernal or our, yes, retrosternal goiter. So it is into the mediastinum. So it's not in the neck, but it is behind the neck. That is in the mediastinum. Okay. So mostly asymptomatic. Mainly it is seen on X-ray, or finding is mostly compression finding. Compression like dyspnea because of compression of airway, dysphagia, esophagus, hoarseness again because of compression of the laryngeal nerve, dilated veins over anterior chest wall, and Pemberton sign. What is that? That, yes, face is congested, that is redness spread on raising both arms. This is called as Pemberton sign. Treatment is obviously we remove this excess thyroid tissue, thyroidectomy. Okay, thyroidectomy is the treatment. Very good. 100% exam question. Now this we have discussed in medicine also, so I will not discuss. We use iodine 123, 125, 125, and for ablation we use 131. So what is used for ablation? 131. This is our Rayu. We have discussed it already, hot, cold. So discuss that very well in my medicine class. So I'm skipping this. I'm skipping it. That is medicine already. Okay. Now what is types of thyroidectomy? Total, we remove all the visible thyroid tissue. Hemi, one of the lobe with the isthmus which connect the two lobes. This is the isthmus. This is the lobes, right and left. This is the eye, isthmus. So if you remove the one lobe with the isthmus, this is called as hemi. Subtotal is only some of the, yes, tissue in the each lobe is left superiorly, this part, rest all is removed. Then Hartley Dunhill is basically we leave single lobe 4 to 6 gram. Okay, that is the case. And near total is just 1 gram of tissue near recurrent laryngeal nerve at ligament of Barry. That is called as the near total. Okay, near total. So total is done only in malignancy, because after the total the person will have hypothyroidism, so we need to give the thyroxine to the patient. Let's see. Indication: benign we do hemi thyroidectomy mainly in benign condition. Okay. Hyperthyroidism we do what? Subtotal in multinodular goiter or hyperthyroidism. Total is done in malignancy. Total is done in malignancy. Okay, that is the case. Okay, if there is both lobe or malignancy, we go for total. Okay, subtotal is done in multinodular goiter. Okay, now what is the most common this STN, solitary thyroid nodule? It is colloid goiter, more common than follicular adenoma. So colloid is more common than follicular. Okay, colloid is more common than follicular. First investigation is we do the what test? We do the TFT. In TFT, we'll see that TSH is less, T4 is more. Then we do FNAC, okay, to check whether it is which kind of tissue, it's follicular one or the colloid. Now, most common cause of worldwide hypothyroidism is Hashimoto, especially rich countries. Rich country, okay, and hyperthyroidism is Graves, which is type 4 hypersensitivity compared to type 2, okay. So rich country is Hashimoto, poor is still iodine deficiency, okay, poor is still iodine. Hello bhai, hello, good evening Dr. Zad. Okay, now grave disease I've discussed very well in our yes medicine, so I'll not discuss much. I'm just HOD. yaad hai, there is what? Hyperthyroidism, ophthalmopathy and dermopathy where there is pretibial myxedema. I've discussed it very well. This is exophthalmos, protrusion of eyeball, pretibial myxedema, tachycardia is there, heart rate there, tremor, eat a lot, shit a lot, constipation, all we have discussed, okay. We have discussed them in detail, so I'm not discussing at all. Treatment is, I told you, if there is thyroid storm, we give propranolol in thyroid storm, okay, for symptomatic relief, okay, and antithyroid is basically for production, okay, plus PTU in thyroid storm. This we have discussed already. So the surgery part I'll discuss because that is not covered in medicine. So antithyroid drugs also we have discussed. The main is methimazole and the pro drug, okay, carbimazole. So carbimazole become methimazole, okay. Now in the case of pregnancy first trimester, we use it is PTU, okay. So it is in first trimester, okay, pregnancy, okay, but not in first trimester. Okay, Monica, please try to open using VPS player. Okay, if you use VPS, it will open. So please use VPS player. If not, you can use Adobe also, but VPS it open. Okay, so my advice is VPS. Okay, next question. PTU is the one which is preferred. So in first trimester, PTU is preferred in first trimester. Okay, first trimester, go for PTU. Okay. Next question, these drugs are given to patient to make the patient euthyroid before the surgery. Okay, even Lugol's iodine was used earlier. Even iodine can be used to decrease the size. Okay, then treatment of choice in Graves is total thyroidectomy in case of older elderly. And yes, if not fit for surgery, then we can do radio ablation. Younger people, we go for drugs. So anti-thyroid are used in younger patient. Older patient, surgery is preferred. Surgery is preferred. Okay. Yes. Now Hashimoto also we have discussed already. So we are not going to discuss. We can skip that part. We have discussed this already. Okay. Sure. Now this also we have discussed subacute in the medicine class only. Okay. So viral infection, then there is hypo, ultimately euthyroid. So we can give pain, so we can give the NSAIDs and the person will recover very well. So steroids can be given and 90% spontaneously recover. Okay. Riddle is a fibrosis of this. There's a massive fibrosis which cause dyspnea, dysphagia, hoarseness. There's the finding of Riddle. Riddle is basically fibrosis is there and the gland is very hard and woody, like very stiff, doesn't get compressed. Okay, so we will do excision. So in this case we do wedge shape excision biopsy where we remove the isthmus of the gland. That is the investigation. Management is we need to give vitamin D and calcium supplementation if there is hypoparathyroidism, and for hypothyroidism we give lifelong levothyroxine. Why? Because the gland is dysfunctional, it's fibrous, that's why we need to give levothyroxine. Okay, now come malignancy. Just give me a minute, I'll take my water and come. My water bottle is not here. 1 minute. Okay. So let's start. First is, okay, so this is thyroid malignancy. So what is there? Thyroid malignancy is there. Most common is, remember, it is our papillary, follicular, last is medullary and anaplastic. So it is only old people, very old people. So that's why papillary is the most. Now it is related to Crohn's disease and thyroid malignancy is there. Younger patient, so remember younger is papillary. याद करना, papillary पापा की परी, तो younger लोगों में होता है पापा की उम्र कितनी है 25 पे पापा बनते हैं, 40 पे पापा की परी फरार. So that's 25 to 40 year. Okay. Seen in iodine sufficient area. So that's a very important thing. Iodine deficit में कौन सा होगा आपका? Iodine deficiency area में what are you going to see? Follicular. तो follicular क्या होता है? Deficient. Okay. Deficient. Okay. Next question. Low dose radiation exposure is a very important factor for the genesis. Okay. Two condition which increase is thyroglossal cyst and Hashimoto, increase the risk of papillary cancer. That is why the findings are very important. याद करना पापा, papillary projection, and remember we see orphan eye and so the eye look like orphan eye in which there is no pupil. So that's why there is no pupil, nucleus is not there. So remember, so this look like this kind of eye, the eye without pupil. So this is called as orphan eye Annie. So orphan eye Annie, you don't see the pupil, same way the cells look empty, that is called as our orphan eye. Clear nuclei is called as orphan eye Annie. Then also there is pseudo inclusion body and dystrophic calcification which look like jalebi, also called as samuma body. They look like jalebis, Indian jalebi. Can you see jalebis? Jalebi. So this structure is very important. Samuma body seen in multiple other condition. What they are? So first PSM. So mnemonic is PSM. P for papillary हो गया एक तो सही है. Then papillary variant of RCC हो गया. S for serous cyst adenoma of ovary and M for malignant melanoma. Sorry, M for meningioma and mesothelioma. M for meningioma and mesothelioma. Next question. What are the clinical features? So there is a midline swelling and sometimes presence of lateral aberrant thyroid tissue. Then most common route is lymphatic because of carcinoma. Carcinoma spread through lymphatics and sarcoma through. How do sarcoma spread through? Anyone? Sarcoma. Those who are watching me live, tell me, how do sarcoma spread? Sarcomas. Sarcoma. How do sarcoma spread? Anyone? Sarcoma. 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 Anyone? Tell me, how do sarcomas are spread? Yes, sarcoma spread through the blood. So it is blood. So blood is responsible for our sarcoma. Clear? So that is a very important finding. So sarcoma is the word we will be using. Okay, chalo. Next question that we see is clinical features हो गया. Then what is the most common site is lungs. La. So lungs is the most common site for the spread. So lungs is the most common site. Chalo. Investigations. So what are the investigations we'll be having or using? So let's discuss that. First is FNAC will do. Later we can do biopsy also. Treatment is total thyroidectomy. Total thyroidectomy. Okay. And removal of the enlarged central nodes of lymph nodes. Okay. Which are plus modified radical neck dissection if lymph nodes are positive. So we'll do this. Okay. Clear? Now follicular. Follicular is iodine deficit area. If iodine sufficient, it's papillary. It is seen mainly long standing goiter. So that's why if there's a hypothyroid goiter, iodine deficiency long, it is seen. It is in 5th to 6th decade. What was younger patients, 25, 30, 40 year? It was papillary. Follicular is Baba log. Follicular is Baba log. Yes, you are all right, Baba log. Clinical feature will be there is a sudden increase in the size of the thyroid swelling. No evidence of compression, dysphagia is there. It spread through hematogenous. Remember, it spread through hematogenous and goes to bones. It goes to bone mainly. Okay, it goes to bone Which bones? Vertebral, ribs, pelvis, skull. So remember differences, papillary versus follicular, 100% exam question. Then comes investigations. FNAC is not sufficient. Why? Because in case of the follicular, what happens? The follicular adenoma and this, what happens? The basement membrane invasion cannot be detected by what? By FNAC. So that's why what is needed? Biopsy is needed. So why do we need biopsy? Because only when there's a biopsy, there would be a which thing? There would be a invasion that is seen. So biopsy is the case. Okay. Management is total thyroidectomy. Okay. Lymph nodes are not involved, so you can spare the lymph nodes. Then come medullary. So दो हो गए हमारे पापा और follicular. So papa, papillary, follicular. Now medullary carcinoma. It is from C cell, which make the what? Calcitonin. That's why there is increased calcitonin, but calcium levels are normal. So medullary is C cell. Medullary is C cell. Clear? Yes. आगे चलते हैं. What are the two types? Sporadic, familial. Sporadic will be single and unilateral. Family, पूरी family आ गई तो multiple लोग होंगे, or it is bilateral. It's a part of men 2A and men 2B, where pheochromocytoma is also there. So pheochromo, we'll discuss it later. So what is seen in elderly? Medullary, 6th decade. So remember, order wise also, papillary younger, then 5th, 6th decade we have the follicular, then 6th decade onward medullary, and 70, 80 year is anaplastic. Remember, sporadic is most common, single sided, unilateral, and if it is younger patient, could be familial. So familial. And what is the gene? It is RET, R-A-T, proto-oncogene mutation. That is the main thing. So, okay, yes, you are right, Dr. Malika. Now, features are increased calcitonin, but normal calcium. Diarrhea is there. Amyloid stroma is present. Okay, when you do the, yes, analysis. Family history is positive of pheochromocytoma, hyperparathyroidism, and our, yes, medullary thyroid cancer. So, these are the things which are positive. रूट ऑफ स्प्रेड इज बोथ, तो याद करना दोनों से जाएगा ये. फॉलिकुलर क्या था? फॉलिकुलर वाज हेमाटोजेनस, पैपिलरी वाज लिम्फेटिक, इट इज बोथ. सो कौन बोथ जाएगा? मेडलरी एम बोथ जाएगा. ठीक है. मोस्ट कॉमन साइड इसकी लिवर है. किसका बोन था? हु वाज बोन? टेल मी, हु वाज बोन, हु वाज लंग? लेट्स सी हु इज लिसनिंग एंड डूइंग इट विद मी. टेल मी, बोन कौन था, लंग कौन है? बता दो. बोन Bone is follicular, lung is papillary. Very good. क्या बात है? Very good. Congratulations. You are doing very well. चलो. Then most this, and it is TSH independent. Why? Because obviously it is derived from the, yes, calcitonin C cell. So that's why it doesn't take the iodine. So that is why we don't do the, yes, radio iodine uptake. Radioactive iodine uptake is not of use, and chemotherapy is also limited. Here again we do FNAC. And treatment is we do bilateral thyroidectomy, ठीक है, plus we do central lymph node dissection, okay, and ipsilateral modified, yes, neck, modified radical neck dissection if more than 1 centimeter tumor. If lymph node is present, then we do bilateral, yes, MNRD, okay. Anaplastic is seen in very old, very old. It is rare, okay. Carcinoma prostate and the anaplastic are seen in 7th to 8th decade. Clinical feature, obviously evidence of compression is there, okay, dysphagia there, and it spread to lungs. Again FNAC. So all we are doing FNAC. Remember, biopsy is preferred in which one? Biopsy in which one? Biopsy. Give the answer. We will prefer biopsy in which one? Thank you, most welcome Manisha. My work is just to help you. If I am reading, I am doing this revision, at least some people will watch and maybe benefited. So even if 10-20 people get benefit, I think it's fine, it's worth it. Okay, because what I feel is now this trend of taking live session, student watching live is ending. Students prefer app, that I've decided. Okay, so for student nowadays, the current batch, they don't want to do live classes, they don't want to attend face-to-face classes. For them only app, okay. So app is their default, is like their Netflix, it is like their Facebook, it is like their Instagram, it is like their Snapchat. For them that is the default, okay. So for communication they use WhatsApp, nothing else, only WhatsApp, okay. For their social media they are using Instagram as their main, okay, for their other things there. So that's why I think app is now superior to each and every mode of teaching, okay. So that's the, I think, final outcome from my experience. So yes, okay, yeah, PDF already I have uploaded in the description. You can click the description, okay. Doctor, which thing? Okay, Gurusevak, just click the description. We are saying na 29 watching. Just click more, and in the more there's a G drive link where you can get, okay. So biopsy is done in follicular because it can't differentiate the adenoma from carcinoma, okay, in follicular, okay. Management, either it is total thyroidectomy and tracheostomy is life saving if this involved, okay. Now parathyroid or adrenal. So what we have already covered in the case of the medicine will not discuss, we'll do the other ones, okay. Okay. But again, people are not happy in I think live classes. That's why very few watch. So again, the entire interest of the faculty die if the people are not watching live, okay. क्या फायदा है ना, अगर बाद में ही देखना है तो फिर क्या फायदा है ना. Now I'm okay. I'm just having slight throat irritation. That's fine. So remember the mnemonic spit. So pan spit किया, ठीक है. So what is the mnemonic? Spit pan para. Spit pan para. So क्या होता है इसके अंदर वर्मर में मैन वन. तो क्या करना है, आपने पान थूकना है. So पिट्यूटरी, पैनक्रियाटिक एंड पैराथायराइड. तो क्या है इसका ट्रिपल पी है. पैरा, पैरा, प्यारा, पान हमने किया. So पैरा, पान और पिट, स्पिट. तो क्या किया हमने, बहुत ही प्यारा पान खा के थूक दिया. सो पैरा पान पिट, पैरा प्यान पिट, ओके. नाउ नेक्स्ट क्वेश्चन, दिस इज गैस्ट्रिनोमा. इन गैस्ट्रिनोमा वी सी गैस्ट्रिक अल्सर्स and we see diarrhea. So there's a diarrhea ulcer combination, it's a gastrinoma called as Zollinger-Ellison syndrome. So now question is, what is the most common in men 1 is parathyroid. So men 1 is para, okay. Manifestation is also hyperpara, which cause again increased calcium, bone breakdown. We have discussed that in medicine, hyperparathyroidism. And yes, obviously the cause is hyperplasia, okay. That is most common, not the tumor. So what is the most common cause of hyperparathyroidism? It is hyperplasia more than tumors. And what is the first abnormality is obviously hypercalcemia due to PTH, and there's also bone resorption. This I have discussed very well in our medicine class. Chalo. PNET. What is PNET? 100% exam question. Pancreatic neuroendocrine tumor. Steve Jobs died because of what? Okay. Steve Jobs died because of PNET. This is inbound. Okay. And what is the most common PNET? It is our man one is PPoma. What is PPoma? अभी तो पढ़ा आपको. Yes, it is spit para pan. So pituitary, pancreatic, and our yes hyperparathyroid. Then gastrinoma, insuloma. Okay, so there are the three. What are they? They are PPoma in the men. Then this gastrinoma, insuloma. Okay. What are the findings of insuloma? There is hypoglycemia, dizziness. It's called as Whipple's triad. Whipple's triad, and sugar improve the condition. Eating sugar improve the problem, that is called as Whipple's triad, okay. And hypoglycemia is yes less than 50, okay. Chalo. Next question, most common functional neuroendocrine, this PNET is gastrinoma, more common than insuloma, okay. So what is more common? Gastrinoma is more common than the insuloma, okay. So I hope that is this, okay. Okay. Chalo, okay. Yeah, thank you, Sandeep. Now, the most common site of gastrinoma is duodenum. MCQ. Some books have given appendix, etc. No, duodenum is the most common site. Now, pituitary tumor I discussed in men 1 is prolactinoma. Then somatostatin, it releases somatostatin, and corticotrophin, it releases the CRH and ACTH. Okay, ACTH. Okay. Now, in man 1, the gene is chromosome number 11, and the protein is a suppressor protein called as mannin. So, it's a tumor suppressor protein called as mannin. Okay. Man 2 is SIPPLE. Man 2 is SIPPLE. SIPPLE का निमोनिक है मध्य प्रदेश PSC या फिर प्राइम मिनिस्टर दिस PSC प्राइमरी हेल्थ सेंटर. सो MP में क्या है हमारा primary health center. Okay, so medullary thyroid is a part, pheochromocytoma P, parathyroid, then Hirschsprung disease and cutaneous lichen amyloidosis. So these are the part. So MP में PSC खोलेंगे, MP में PSC is meant to A. It is meant to A. Meant to A. Yes. Now medullary carcinoma thyroid and pheochromocytoma are part of MEN 2A and B. ये बहुत बार पूछा है आपका. So medullary carcinoma and pheochromocytoma, they are part of MEN 2A and 2B. Okay, plus parathyroid. Okay, plus parathyroid, hyperparathyroidism. ये तीन हो गए इसके. That make our 2A 2B. In one, what was there in men? वही पान पिट प्यारा, पान पिट प्यारा. तो इसमें क्या होगा? पैनक्रियाटिक भी है, पिट्यूटरी भी है. सो पैनक्रियाटिक पिट्यूटरी किसमें आ गया? मैन 1 में. और अगर फियोक्रोमोसाइटोमा इज देयर, फियोक्रोमोसाइटोमा एंड द पैराथायरॉइड, then it become, and medullary thyroid, this become our, these three are the main, are meant to, plus extra Hirschsprung disease and cutaneous lichen amyloidosis. So that is the case. Okay, for the gene mutation, it is again RET oncogene on chromosome number 10, and the, yes, cysteine codon is mutated, which is the tyrosine kinase which cause increase protein formation, proliferation and tumor is formed. अब एक नया तीसरा आ गया आपका MEN 3, also called as MEN 2B. इसमें एक्स्ट्रा आता है क्या? न्यूरोमास. तो अगर आपका थायराइड है, मेडलरी, फियोक्रोमोसाइटोमा है, प्लस इफ देयर इज अ न्यूरल वन, दैट इज MEN 3 और 2B. सो MEN 2A, व्हाट इज देयर? देयर इज व्हाट? देयर इज फियोक्रोमोसाइटोमा, medullary thyroid, and also what is there? There is going to be parathyroid. So अगर parathyroid के साथ में it is MEN 2A. If there is neuroma or ganglioneuroma, then it become what? Then it become our MEN 2B. तो एक बार इसको कर लेते हैं. MEN 2A, MEN 2B में क्या फर्क है? तो आओ देखते हैं. Anyone, MEN 1 में क्या क्या आएगा? MEN 1 में, और MEN 2 में क्या क्या आएगा? Anyone? बता दो भाई. MEN 1 सिंपल एंड वर्नर. आओ देखते हैं इसमें क्या आएगा. आपने पान खा के थूक दिया, प्यारा पान, प्यारा पान स्पिट, ये हो गया आपका. तो पैराथायरॉइड, पैनक्रियाटिक, पैनक्रियाटिक में अगेन गैस्ट्रिनोमा एंड पिट, पिट, पिट में क्या आएगा? पिट, उसमें क्या आएगा? गैस्ट्रिनोमा. पैनक्रियाटिक गैस्ट्रिनोमा मोर देन इंसुलिनोमा. ओके, यस. एंड पिट, पिट इज पिट्यूटरी. पिट्यूटरी में, यस, अवर विच वन? पिट्यूटरी में विच वन वाज द पिट्यूटरी? बताओ. पिट्यूटरी में कौन सा था मोस्ट कॉमन? लेट्स यू आंसर. प्रोलैक्टिन. वेरी गुड. मोर कॉमन देन अवर कॉर्टिकोट्रॉमा और सोमैटो, देन सोमैटो, देन कॉर्टिको. ये सारे एग्जाम क्वेश्चन है, मजाक नहीं कर रहा मैं, ठीक है. MEN 2 में क्या चीज कॉमन है? एक तो मेडलरी थायराइड प्लस कौन सा? फियोक्रोमोसाइटोमा. वेरी गुड. अब A और B क्या होगा? 2B को 3B बोलते हैं. इसमें क्या फर्क है बता दो. फियोक्रोमो दोनों में, फियोक्रोमो दोनों में बच्चों. इसमें क्या होगा एक्स्ट्रा? क्या मिसिंग है सोचो. यस, पैराथायरॉइड, पैरा. सो पैरा आएगा तो इसमें जाएगा. इसमें न्यूरोमास है, न्यूरोमा. सो अगर न्यूरोमा हो गया तो ये जाएगा 2B और 3 में. अगर नहीं है न्यूरोमा तो ये आपका 2A में जाएगा, जिसमें पैरा आ जाता है. वेरी वेरी गुड. प्राउड ऑफ यू ऑल. ओके, वेरी गुड. सो यू आर डूइंग. एंड बोथ में जीन कौन सी गई है? रेट जीन. व्हाट इज गॉन? रेट जीन इज गॉन. रेट जीन. सो RAT, रेट जीन इज गॉन. ओके, सो न्यूरोमा इज द हॉलमार्क. सो अगर न्यूरोमा दे दिया भाई साहब उन्होंने, देन इट इज 3 और 2B. ओके, चलो. Again, gene is same, RAT, RET oncogene, and there is tyrosine kinase which cause more and more. Okay, चलो. Now, MEN 4B आ गया है. MEN 4 is cyclin, is not tyrosine. 2B और में इसमें tyrosine था. क्या था इसमें? टायरोसिन काइनेस, रेड जीन टायरोसिन काइनेस, इसका म्यूटेशन था जो ट्यूमर कर रहा था। 4 में क्या आएगा, 4 में आएगा साइक्लिन। So cyclin is involved. Okay, cyclins are the group of protein which regulate the cell cycle. I'll discuss cell cycle later. Okay, so इसमें आएगा आपका cyclin dependent kinase. They regulate cell cycle. अलग अलग स्टेज G1 M all. Okay, so chromosome number 12. What was ret? Ret was 10. Ret was 10. Ret was 10. This is 12. इसमें क्या आएगा, देखो इसमें सारे, इसमें पैरा भी है, थायराइड भी है, पैनक्रियाटिक भी है, एड्रेनल भी है, रीनल, मतलब ऑलमोस्ट ऑल, ऑल आएगा। सही है, इसमें क्या आएगा, ऑल। तो एचपी, एचपी, ओके, एचपी हिमाचल प्रदेश, टारगेट, टारगेट, सो थायराइड, एड्रेनल और रीनल एंड गोनाड इज जी, सो टारगेट। सो 4 मेन 4 का टारगेट है एचपी, एचपी, सो एचपी इज द टारगेट। ओके, एक्स, ओके, तो याद करना एचपी टारगेट, निमोनिक है, एचपी हिमाचल प्रदेश टारगेट है रिटायर होने के लिए। जाते लोग कहाँ रिटायर होते हैं, यस, वो जाके कहाँ पे बस जाते हैं, दे गो टू मनाली या हिमाचल में कहीं जाके अपना हिल स्टेशन पे रिटायर हो जाते हैं। कहाँ पे, मनाली में रिटायर हो गए। ठीक है, तो एक बार देख लेते हैं। तो कैन यू टेल मी मैन 4 में क्या क्या आएगा बच्चों, मैन 4 में आओ क्या है, निमोनिक, एचपी टारगेट, टारगेट, एचपी टारगेट। बताओ भाई एचपी में क्या क्या आएगा, एनीवन, व्हाट इज एच एन पी, एच एन पी। देखो दो तो इसके वही है, थायराइड वाले हैं, एक है आपका, यस, एच से क्या आएगा बता दो, हाइपर पैरा, वेरी गुड, हाइपर पैरा है, और टी से थायराइड है, वेरी गुड। पी से, पी से, पी से व्हाट इज पी, ए से एड्रेनल हो गया, पी से पैरा, वेरी गुड, आर से रीनल, एड्रेनल, जी फॉर गोनाड, and what is the 1p, very good, pancreatic। तो फियोक्रोमोसाइटोमा को छोड़ के सारे ये याद कर लो, फियो नहीं है इसमें, फियो नहीं है, बाकी सारे हैं। तो व्हाट इज मिसिंग, फियोक्रोमोसाइटोमा एंड पिट्यूटरी इज मिसिंग, एंड पिट्यूटरी आर एब्सेंट, बाकी सारे मैन 4 में। एंड आई एम नॉट जोकिंग, एज पर माई एक्सपीरियंस टीचिंग सो मेनी ईयर, आई हैव सीन मैन सिंड्रोम आस्क ऑलमोस्ट एवरी ईयर। ओके, सो ऑटोजोमल डोमिनेंट है ये, और क्या होता है याद करना, मैन 1 में आपका 11 पे था क्रोमोसोम, मैन जो मैनिन बनाता था, विच प्रोटीन, मैनिन प्रोटीन, जो कि ट्यूमर सप्रेसर है। रेट वाले क्या है आपके, 3 हैं, और 3 को क्या बोलते हैं, व्हाट द अदर नेम ऑफ 3, एनीवन, 3 इज ऑल्सो कॉल्ड एज व्हाट, अदर नेम, 3 3 3 3 2b, मैन 2b, and 4 is cyclin, so cyclin dependent kinase, very good, congratulations, you have done a very important topic which is called as our man syndrome। अगर man आया, please thank your good time that you watch this and discuss। okay, चलो, एड्रेनल इंसिडेंटलम, ये क्या आपका, इंसिडेंटल मतलब कभी कभी एक्सरे में दिख गया या सीटी में दिख गया, दैट इज द केस। ओके, ज्यादातर क्या है, ये नॉन फंक्शनिंग एडिनोमा है। डन कब करेंगे सर्जरी इसके लिए, जब एक्टिव होगा। सो अगर एक्टिव है विल गो फॉर सर्जरी। ओके, इंक्रीज रिस्क इज देयर इफ देयर इज अ इंक्रीज साइज। ओके, चल, मैनेजमेंट ऑब्वियसली वेरी बिग सर्जरी, इफ 3 to 5 may do, and less than 3 CT for yes monitoring। okay, now pheochromocytoma I have done it 100 times in medicine, I'm not doing it, I am skipping it, I've done that already, headache, palpitation, all this, so I'm not doing anything, I have done that। okay, MIBG is done for extra and also for metastasis, PET scan is the gold standard for staging and metastasis, right bracket, metastasis। And don't do FNAC biopsy because it can cause leakage and hypertensive crisis। Treatment is, we first, if there's a shock or volume depletion because the person is dehydrated because of excessive urination due to polyuria, so patient is having high pressure, he has polyuria, so need to give fluids, and then control BP, we use phenoxybenzamine before surgery। I think this I have discussed multiple times during surgery, phentolamine। okay, and if tachycardia we can add beta blocker, but never give beta blocker alone। treatment is surgery and removal, I discussed that already। okay, Now come our hernia. Very, very important topic, that is our hernia. So let's discuss the hernia and abdominal wall. So what is the most common type of hernia? If they ask in both male and female, it is indirect. If they say what is more common, femoral is more common in female, inguinal more common in male, and what is both most common hernia in both? Indirect inguinal. It is what? Indirect inguinal. So this is the anatomy. So look at the anatomy. This is the hernial sac. This is external inguinal ring. This is pubic tubercle. There's the landmark pubic tubercle. This is sac of femoral hernia. This is the femoral hernia. This is your indirect inguinal one. This is our femoral vessels. Which one? Nerve, artery, vein. So navy है ना ये, NAV. So ऊपर nerve है, फिर artery है, फिर vein है, and this is your iliacus. Okay, and this between this is your, so between the ASHISH, what is ASHISH is? Yes, ASHISH is our what structure? It is anterior superior iliac spine. It is connected here. Okay, and this is our internal inguinal ring. This is our external inguinal ring, and what crosses? The inferior epigastric vessels cross it. ये इनके vessels हैं. So this is inferior epi. That help you differentiate direct from indirect. So what help you differentiate? The inferior epigastric artery will differentiate whether it is direct, indirect. Let's see that. Now remember, first question. Deep ring is defect in fascia transversalis and superficial ring is the defect in external oblique. So remember, deep is fascia. तो अंदर क्या रहेगा? Fascia. Fascia फंस गए अंदर जाके, और X आपकी बहुत superficial था या थी. तो who was very superficial in their thing? X. So X is superficial. तो क्या थी X आपकी? Very superficial. And आपके जो best friend है fascia, fascia is deep. So remember, friends are deep. Yes, it's 100% exam question. Yes, Dr. Ved Prakash. So it was asked in INICT also and NEET PG. Let me ask you question and tell me. Okay, tell me superficial ring and deep ring. What are the location of them? They are opening or defects in which structures? Superficial is a defect in which thing? Superficial. Anyone? Superficial is a defect in anyone? Yes. So superficial is your what? X, external oblique, and deep is fascia transversalis. Very good. So deep ring is fascia, superficial is X. So आपकी X क्या थी? Superficial लव करता था या करती थी, और deep कौन है? Friends. Friends go deep. चलो. Next question is our write down the concept is indirect किससे आएगा? Deep से. So मैंने कहा ना indirect. So आपका indirect is through the deep. Okay, this one is the indirect जो deep से आ रहा है आपका. और अगर आपका किससे आएगा? If it come through the which one? So that is indirect. Okay, and coming out via the superficial inguinal. Whereas direct is directly through inguinal canal via triangle of Hasselbalch. So triangle of Hasselbalch. So indirect कहाँ से आ रहा है आपका? Yes, deep ring and transverses the inguinal canal and then come through the superficial inguinal ring. So that is not coming through the canal but indirectly coming. Whereas direct come through the inguinal canal. So what is coming through the inguinal canal? The direct one. Indirect one come through the, yes, our deep ring and then superficial one. Okay, so that is indirect one. So that is the indirect one. Okay, so question is, what is the important thing? Okay, so boundaries of the triangle of Hasselbalch. So it is first laterally inferior epigastric. So what is there? Laterally inferior epigastric. Medially there is a lateral border of rectus abdominis, and inferiorly is the inguinal ligament. So that is the inguinal. Okay, so this is the area where the direct will go. This is the Hasselbalch triangle. Okay, these are the vessels. Which vessels? These are epigastric vessels. Below, what is there? This is what below? Inguinal. Which one? Yes, ligament. And this is what structure? This is our which muscle? Yes, this is rectus abdominis, rectus muscle. So I'm giving the yellow color to mark it. So this triangle, the green one, this green one is our Hasselbalch triangle. And if you go through Hasselbalch, you are a direct one. So that's why if a tumor is medial to the inferior epigastric artery, it's a yes direct one. If you are lateral to this is indirect one. So I'm giving the red color here. This is indirect. So very simple rule. Look at the artery. Which artery? Inferior gastric artery. If you are on the yes medial side, अंदर की तरफ हो, तो आपका ये कौन सा है? डायरेक्ट है. अगर आप उसके बाहर हो तो ये इनडायरेक्ट है. लिखा हुआ है वैसे तो, पर फिर भी मैं लिख देता हूं इसके अंदर. इट्स वेरी इंपॉर्टेंट. सो आई जस्ट राइट डाउन. सो क्या है आपका डायरेक्ट इनडायरेक्ट का? सो डायरेक्ट इज मीडियल to the vessel, this artery, epigastric, IEA, and indirect is lateral. ठीक है? So I think it's clear now. So that is the story here. Okay. Next question. Okay. What is the relationship? So indirect, the sac is anterolateral. Direct, it is posterior. So where is the spermatic cord relationship? So that is posterior or anterolateral. Okay. Now relation of the neck. So remember, the neck of the sac is above and medial to the medial tubercle. This is a medial tubercle, the one here. If it is yes above and medial, this is your indirect one. Okay. And if it is our which one? Femoral, it is below and lateral. So this is femoral and this is indirect. So remember, if it is below and lateral to the this, it is our femoral. This is femoral. This is below and laterally, left, laterally. And if it is our medial, it is our which one? It is our yes indirect one. Okay, it is the indirect one. Okay. So I hope it's clear. Types of indirect. So what are the types? So first is bubonocele. What is bubonocele? The hernia content are limited to inguinal canal. Funicular is processus vaginalis is closed just above the epididymis, and if it goes the testes would lie in the lower part of hernia. This is called as complete or scrotal. So they are what? Indirect inguinal hernia. So these are the indirect inguinal ones. Okay. तो तीन क्या है? Bubonocele, funicular and complete scrotal. Okay. बस याद करना कहां तक गया. अगर पूरा कनाल तक चला गया but not entering this testes, it is incomplete or it is your funicular. If it is midway somewhere कहीं अटक गया superficial या deep ring पे, so if it is there, it is called as our bubonocele. If it reaches called as processus vaginalis, if it reach all the way to the testis scrotal sac, then it is called as complete. So complete is scrotal sac. Now it's very important. Okay, this is the gut and ये 100% exam में आता है 100%. Which topic? The types of the hernia. Reducible. When do you use the word reducible? If the content can be pushed back into the abdominal cavity, it is called as reducible. If they can be pushed back, it is reducible. Irreducible is you cannot push it out. It stays because of addition between the sac and the intestinal loops. There is a gut. So gut is now attached to the sac, so it cannot go back. But the lumen of the gut is intact. The movement, that is when the person eat, the movement will still occur. That means there is no obstruction. So that is called as irreducible, but there is no obstruction is there. No obstruction is there. Okay, obstruction is not there. That's why it's still functional, less dangerous. Okay, incarcerated. What is incarcerated? Here the hernia contain fecal matter which causes the increase in the size, and now it cannot be pushed back, and that is why it is difficult. So two kind of irreducible. One is our attachment or additions are there, or there could be fecal matter which produce it to be reduced. So that are the two cases. Okay, clear? Then finally obstructed is the obstruction is there. There is no movement in the gut. Obstruction is there, but blood supply is maintained. The neck is not very narrow. That is why there is there is blood supply maintained. Okay, the mesenteric vessels are working. Strangulated is the most dangerous. It is dangerous. Why it is dangerous? It is a danger. Why danger? Because now there is compression of the blood vessel. Now gangrene will occur, and after gangrene there could be multiple complication. There could be peritonitis can be there, because once there is a necrosis etc., this lead to release of the content into the peritoneal cavity. Severe inflammation, infection will occur. So very dangerous. Now enterocele versus omentocele. If intestine enter, intestine is called as what? Enteric. Enteric is intestine, and that is the case. And omento is basically, omentum is the content. Okay, what is the difference? If intestine, first part is difficult to reduce, but later on it easily move, and you can see peristalsis of the gut. So gut show peristalsis. But if omentum is the content, first part is easy to reduce, last part is difficult. So it is, remember, if intestine शुरू में मुश्किल, बाद में easy, end is easy. So remember end. So end is easy. Entero, end is easy. And oma, initial is our easy, last is difficult. So here end is difficult. Oma is this. Content is doughy. Here we see the gut part and peristalsis. Okay. Example, first is Litter's hernia. What is Litter's hernia? In Litter's hernia, the content is Merkel's diverticulum, and the Amanens hernia is appendix. So Amanens is appendix, Litter's is Merkel's. So Litter's Merkel's. Okay. So this is the case. If appendix come in the hernia, this is Amanens. If Merkel diverticulum, it is Litter's. Okay, is very uncommon. It's very rare. But diagnosis is purely clinical. Examination is done. Okay. And exception is internal hernia. Obviously you can't see, so need to do CT, MRI or ultrasound. That's the case. Or Spiglian. Spiglian is a very important one. We'll discuss. Treatment of hernia is basically herniotomy. We'll open it up. Herniorrhaphy. That is, we strengthen the inguinal floor to prevent the reoccurrence. And last is hernioplasty, where you put a mesh. So mesh is plasty, rhaphy is strength, increase the strength, उसको बनाएंगे strong. So rhaphy मतलब उसको बनाएंगे powerful, rhaphy. Okay. And herniottomy is, obviously we open the hernial sac, that is opening. So open the hernial sac, reduce the content back into the cavity. Sometimes we also do inguinal canal reconstruction. Okay. Chalo. Now what are the types of repair? Bassini and Scholdice. Okay. Ruffini and Scholdice. Now what is the main thing? If it is tension free, it is Lichtenstein repair. So what is Lichtenstein? It is the case, and it is a gold standard. MCQ यही पूछते हैं आपसे, gold standard कौन सा है? Lichtenstein appear. Lichtenstein. Okay. So बिल्कुल आइंस्टीन वाला है. ठीक है. I'll repeat in the end. Okay. अभी flow में करते हैं ये. End में I will repeat. Okay. Next is, if there is laparoscopic, then it is two type. TEP, total extraperitoneal, or TAP, that is trans-abdominal pre-peritoneal. So क्या हो गया? TIP और TAP, TIP-TAP. So TIP-TAP, TIP-TAP. ये क्या है आपके? ये हैं आपके laparoscopic repairs. Okay. Finally, what is Bassini, which we discuss? Bassini is triple layer repair. So what is Bassini? Triple layer. So यहाँ लिख देते हैं triple layer is Bassini. Okay. And gold standard is our Lichtenstein. Gold standard is Lichtenstein. Okay. Then our, the Scholdice. In this case, 4 layer is there. We do double breasting of the fascia transversalis, and modified is 6. Modified is 6. So let me see. So if triple layer, Scholdice is 2 type. It is modified, and this it is 4 layer, because we do double breasting, or modified is 6. क्यों करते हैं? डबल ब्रेस्टिंग। तो उससे कितने हो गए? 2 into 3, 3 into 2 या 2 is 6, so डबल ब्रेस्टिंग। डबल ब्रेस्टिंग, सो डबल ब्रेस्टिंग इज देयर। ओके, चल आगे चलते हैं। नाउ Shouldice compared to Bassini has decreased tension and decreased recurrence. Why? Because you're doing double breasting. Why? Due to double breasting. Obviously बात है, ज्यादा strong हो जाएगा double breasting. Okay, so that is the story. Now landmarks, I'll just discuss the important one. Most common injured, ये क्वेश्चन आपका आया था नीट पीजी में, नीट पीजी 23. I myself gave and I knew this question. So the question was our most common injured nerve during laparoscopic hernia repair is which one? It is our lateral cutaneous nerve of the thigh. What the nerve is? Lateral cutaneous nerve of the thigh. So कौन सी nerve है ये आपकी? Lateral cutaneous nerve of the thigh. So lateral cutaneous nerve of thigh. Done. एंड ओपन है अगर, तो ये होगा आपका इलियो इंग्वाइनल। सो रिमेंबर इफ लैप्रोस्कोपिक लैटरल, लैटरल ला, तो याद करना ला, लैप्रो में लैटरल जाएगा, लैप्रो में लैटरल जाएगा। एंड इफ इट इज ओपन, इट इज इलियो इज ओपन। सो इलियो इज ओ, इलियो इज ओपन, लैटरल इज लैप, इलियो इज ओपन। सो ओपन में इलियो open. So please remember them, it's very important. Okay, now comes the question, strangulated hernia. As I discussed, there's the impaired this, so that's why there's going to be what? Yes, infarction of the gut. So incision is given over the most prominent part and suction should be ready, so there is fluid rich in bacteria. So whenever there's an obstruction, bacteria grow very well. Next is prosthetic mesh is contraindication because increased risk of infection. So yes, we can use absorbable mesh in this case. Okay, अब आगे आपका फेमोरल्स, फेमोरल। ओके, मोस्ट कॉमन इन फीमेल। सो रिमेंबर फीमेल में क्या होता है आपका? फेमोरल, मेल में इंग्वाइनल, मेल में इंग्वाइनल। ओके, मोस्ट कॉमन ऑन राइट साइड, राइट, तो याद करना फीमेल इज ऑलवेज राइट एंड यस मोस्टली यूनिलैटरल। ओके, मोस्टली यूनिलैटरल, तो याद करना फीमेल इज ऑलवेज राइट, तो याद करना फीमेल इज राइट। ओके, और अपनी मर्जी करती है तो मोस्टली यूनिलैटरल, 20% है बाइलैटरल। तो याद करना फीमेल दे डू व्हाट दे वांट, सो यूनिलैटरल डिसीजन मेकिंग, प्लस दे आर ऑलवेज राइट एंड दिस। हेलो भाई मुकेश, कैसा है मेरे भाई? क्या बात है, कॉन्ग्रेचुलेशन भाई फॉर ज्वाइनिंग इन GMCH पूर्णिया। स्टडी हार्ड, वर्क हार्ड, बी द बेस्ट इन योर फील्ड, दैट इज व्हाट वी विश फ्रॉम यू। ओके, next question, so it's very common multipara because of the ligaments become lax. So याद करना with age every ligament become loose, that is the case. तो क्या होता है? ढीला ढाला पड़ जाता है तो आसानी से क्या हो जाएगा? हर्निया हो जाएगा। ठीक है, चलो, femoral ring and the canal is both similar in this case, that is why it's very common to yes have the hernia. Now management, बस याद कर लो लो, तो क्या करना है? फीमेल को लो क्या देना? उसको लॉकवुड और यस Lothanson inguinal, Lothanson inguinal. Okay, most common use is EVD, most common is EVD, बाकी के हैं। ठीक है, so treatment of choice पूछे तो हेनरी याद कर लो। Again I don't know, okay, I will not lie, I don't know about this surgery, I never have seen these surgeries. Okay, why should I lie? Okay, I'm not someone who lie, I'm here as a faculty who is having the knowledge of surgery as good as just a MBBS student. Okay, I'm just doing a revision. Okay, so I don't know this topic myself, I've never done this surgery, I've never even seen these surgeries getting done, so my knowledge is superficial, I'll myself say. Okay, if someone say which is the best surgery, these are notes of faculty from the textbook, so I'm just trying to help you revise, I don't have my own. Okay, कहाँ से start कराएं? वेला, we are not able to survive in Delhi itself. Okay, we are not having admissions in Delhi. मुंबई क्या करेंगे यार? ठीक है, and yes, if that goes on, one day will completely shut down, there will be no classes, nothing, everything will be shut down, everything will be closed. Okay, I don't know what will happen if you people support, but I don't know why people don't support us, that's something very mysterious. ओके मैं इतने टाइम से कह रहा हूँ सपोर्ट, उल्टा एडमिशन कम ही हो जा रहे हैं. ओके डिक्रीजिंग डिक्रीजिंग. आई थिंक पीपल वांट टू शट डाउन, इवन स्टूडेंट्स वांट अस टू शट डाउन. सो मे बी आपकी मर्जी, जनता है भाई. आपने मोदी जी को हरा दिया, हम क्या चीज है. चलो आगे चलते हैं. वेरिएंट्स ऑफ फेमोरल हर्निया. फर्स्ट इज लैंगुअर्स हर्निया, is through lacunar ligament. Cloquet is the behind pectineus and Narath is behind, पीछे होगा femoral vessels. Okay, femoral vessels. ठीक है. Okay, अब आ गया spine, Spiglinian. So what is Spiglian hernia? It is at or below arcuate. So arcuate है, इसे बोलते हैं interparietal hernia. क्या बोलते हैं इसे? Interparietal. So not visible. तो which is the spine? छुपा हुआ. स्पाई नहीं खेलते, आई स्पाई. तो स्पिगलियन क्या है? स्पाई की तरह छुपा हुआ है, हिडन है. व्हाई? बिकॉज इट इज कंटेंट इज बिटवीन द टू मसल लेयर, सो दैट्स व्हाई दे आर नॉट विजिबल एंड दे आर नॉट ऑब्जर्वेबल आल्सो. सो व्हाट टू मसल? इन और एक्स के बीच में फंसा है, ओब्लिक, इंटरनल ओब्लिक, एक्सटर्नल ओब्लिक. दैट इज व्हाट स्पिगलियन. ओके स्पिगलियन. Okay, that is the case. This is the one which is showing the photo. Now we need to do ultrasound or CT and we need to do content inversion and close the defect. So content inversion and we will be, yes, reversing the defect. Okay. Sliding. Sliding is basically what happens in this case. It is going in and then can come out. That is called as sliding. Okay. Sliding is called as glissid and glissid. Okay. तो क्या होगा इसके अंदर? Viscera is the posterior wall of the sac. Males is very common and left side. So mostly it is left side and contains sigmoid colon. So left side sigmoid, right side is cecum. So if right side cecum, left side sigmoid colon. So right cecum, left sigmoid. That is sliding hernia. Okay. Next question. Management is invert the sac. So we have to invert the sac and then repair the defect. Okay. Lumbar hernia. Okay. So it is basically in the lumbar region, posterior. So most hernias are anterior. Okay, this is the one which is posterior, lumbar. Okay, can be congenital, acquired, and there are two triangles which they ask. One is superior or inferior. That is Grenfell or Pettit. Okay, inferior is Pettit. छोटा है तो उसको Pettit. और gray मतलब बड़ा हो गया, older, gray. Now management is Daud's. So Daud's operation. Then come obturator. It is old skin. ये एग्जाम में आता है. Old obturator. Old is obturator. Also called as French hernia. Seen in, yes, क्या ना, elderly patients, very thin patient, malnutrition, multiparous with ligament and constipation is there high. So remember, old female constipated with multiparous, lots of kid, she has obturator hernia. Okay, so किस में जाएगा? Obturator canal में चल जाता है and there is obturator nerve and vessels in canal. Okay, चलो. So इसमें क्या आएगा आपका? There is a involvement of obturator nerve which lead to pain in the inner aspect of thigh radiated to the knee joint. That is called as Hauschiff-Romberg sign. MCQ. So Hauschiff-Romberg sign is seen in obturator hernia. Obturator is old female, thin female, constipated, multiparous, and there is a hernia in the obturator canal which contain the obturator vessels and nerve. That's why there is a very special sign. The pain is radiating from medial side of thigh to the knee joint. Also there is Hannington-Kiff sign. That is absence of obturator reflex. Okay, because of the compression of the obturator nerve. So the obturator reflex is absent. Management is posterior approach will do the repair. Okay. Now epigastric, para-umbilical and umbilical hernia. So what we are discussing? Yes, we are discussing epigastric, para-umbilical. Good evening, Dr. Diyasha. And umbilical hernia. So umbilical is basically, this is umbilical, sorry, this umbilical, around it is para-umbilical. So umbilical is when directly into the umbilicus we are having the, this is the umbilical, and nearby area is 2 centimeter. This para-umbilical, this is umbilical, and epigastric is this area above the, yes, xiphoid till umbilicus. So this is epigastric, this is U, and this area is para. So I've given all the signs here, para, epigastric and this. Okay. Okay. Now basically epigastric is also called as fatty hernia of linea alba. So in the midline, then it contains fat and That's a defect in linea alba. In the middle, linea alba is what? See, there are two muscles, rectus abdominis. Where they fuse is called as linea alba. If there is a defect, there could be, yes, fat protrusion, and this can cause ischemia and pain. So sometimes it mimic peptic ulcer. So obviously we need to excise the fat and correct the repair and put a mesh. Okay. Then there is something called as incisional hernias. What is the next topic? Incisional hernias. What happens in incisional hernia? After any kind of, abdominal wall opening, if the hernia goes through the incision, it is called as post-op ventral wall hernia. That is आगे की wall में से hernia. So क्या होता है इसमें? The failure of fusion of the tissues causes the hernia, and it is mainly seen in the case of long midline vertical or lower abdominal incision. एग्जाम में पूछा हुआ है, तो which incision increase the risk? एक तो long, जितना लंबा होगा उतना fusion weak होगा. Midline, again there is a this midline, there fusion is very poor, so that's why midline there is aponeurosis, which doesn't fuse very well, doesn't heal very well. And finally vertical ones, because you are cutting fiber in their opposite direction. Okay, so fiber are parallel. If you are cutting vertical, again healing is poor and the fusion is poor. So that's why remember, long midline vertical and also lower abdomen, they all carry the risk. Okay, chal. Okay, this I'm skipping because I've never seen a question on European this incisional hernia, so I'm skipping that part. Management is obviously we do laparoscopic preferred over open hernia repair, and we can do mesh repair. Okay, then omphalocele or axomphalocele. एग्जाम में कई बार आता है, ये पीडियाट्रिक्स में देते हैं. अ बेबी फोटोज गिवन एंड यू सी दिस, द इंटेस्टाइन failed to go back to the abdominal cavity is called as our omphalocele or axomphalocele. Okay, so they are covered by 2 layers of peritoneum inside and amnion outside. So what is covering them? 2 layers of peritoneum, and also the amnion is covering them outside. That's the question. Basically related to all trisomy, that is Patau down Edward. Okay, so 13 is Patau, 18 is Edward, 21 is down. So all trisomies can do the, yes, omphalocele. It is a very common acid in this case. Okay, and if CVS, it can cause death. So if there's a CVS anomaly, death can occur. Okay, chalo, I'll discuss, don't worry. Okay, so if stomach part is coming, is gastroschiasis. Here stomach is coming out, here intestines are coming. Okay, Monica, that's the main difference. Okay, we have to check the contents. Okay, prognosis is poor, and variant of Wilms tumor is back with Wildman syndrome. Okay, now bowel is exposed. So if bowels are exposed, okay, and mainly the, yes, stomach is also there, and this defect is mainly right side of umbilical cord. Okay, that is gastroschiasis. So exposed bowel is the one. Okay, so exposed. Okay, desmoid tumor, very, very, very important. It is extra abdominal, mostly it's outside the abdomen. Abdominal wall is 25%. That's the case. Okay, first question, if abdominal, it is infra-umbilical. This is your open wall. Can you see? The bowel is exposed. So this is exposed bowel. Gastroschiasis is not covered by the layers. See which case they are covered. Can you see covered? So covering amnion outside and 2 layers of the peritoneum inside. That is in omphalocele. If it is not covered, exposed bowel, this is gastroschiasis. Are you clear now, Molika? So it is, yes, covered, uncovered. That is, see, this is uncovered. Okay, if covered, this is which one? If covered, this is our omphalocele. Chalo. Next, no distant chain, no sarcomatous change, and no this distant, but risk of recurrence is there. That's why we need to do first biopsy, and then we do wide local excision of the dermoid cyst. Okay, of the dermoid, so desmoid cyst. Okay, now important hernias, ये एग्जाम में आता है, एक बार करते हैं. Gibbons is hernia plus hydrocele, double problem. So hernia, hydrocele. Berger is when Douglas. So याद करना, मैकडॉनल्ड्स का बर्गर आता है, डोनल्ड्स. So मैकडॉनल्ड का बर्गर आता है, so बर्जर. So बर्गर कौन सा है? डगलस. बर्गर इज डगलस. ओके, yeah, I know photo came. Okay, backlards. Backlard is basically saphenous opening. If saphenous is backlard. Okay, then ogilyphs दिस ग्लिप्स कब होगा आपका कंजॉइंट टेंडन. ओके, स्टैमर इज ट्रांसवर्स मीजोकोलोन after surgery, that is gastrogynostomy. Okay, Peterson is behind raw limb. Okay, or raw and y gastric bypass is Peterson. Then Valpew is prevascular. Sarah Finney is basically retrovascular. So Sarah Finney is retro, Valpew is vascular. Wow. Again, I'm telling you, I'm just teaching, not teaching, I'm just repeating what's written. I myself have very little idea about this hernias, because only a person who is trained in surgery department will see all this hernia. Otherwise, for us, they are just facts. Okay. Finally, there is Holthaus. What is this Holthaus? It is inguinal, but basically bowel along with inguinal ligament. That is called as Holthaus. So I think this more than sufficient. Last ones is our Richter's hernia. Okay. See, I told you that part I will cover in medicine. So I'll take a session of medicine in which I will cover them, especially all the hepatitis. I've discussed that in brief already. So I'll cover them there. So don't have to worry about that. It'll be covered. Okay. Chalo. Next is Richter's. Richter's is basically part, not the full circumference, but some part of the circumference is going, and that's why bowel is going to sense the obstruction, lead to hyperperistalsis, and the content are moving distally. So that's why it mimic gastroenteritis. Why? Pain is there, diarrhea. So diarrhea, pain in which hernia? Richter's. So Richter's is like yes. So कैसे याद करोगे? Richter's scale used for earthquake. Earthquake की तरह इसको डायरिया आ रहा है और पेन हो रहा है. So that's the case. Now ये क्वेश्चन आता है triangle of doom. Triangle of doom. It is the medially vas deferens, laterally gonadal vessel, base is peritoneal edge, apex is deep. This is the triangle. What is there? It contains iliac vessels. If they are damaged, it can cause severe ischemia of the limbs. So it's very dangerous. So it is the case. So if any dissection in this area, it can damage the iliac vessels and severe hemorrhage, death will occur. So that is very dangerous. So for the triangle of doom in the lower limbs area, it is the one which contain inguinal vessels. Okay, clear? So iliac vessels. Okay, what are the boundaries? Vas deferens is there. Vas deferens. This is vas deferens. Then we have the gonadal vessels and peritoneal edge. Then come triangle of pain. So it is basically yes, medially gonadal vessels, superiorly there is the iliopubic tract, laterally peritoneum, content is 4 nerves. So any of the nerve injury, pain will be there. What are the nerves? It is femoral nerve, femoral branch of genitofemoral, okay, anterior cutaneous nerve of thigh and lateral cutaneous nerve of the thigh. So with this we'll take a break, then we'll continue after break. So we'll take 15 minutes, okay. Already we are covering mock tests, we have given the dates. So 15 minutes break. I'll start at 9:50 p.m. 9:50 p.m. Okay, let's take a small break, then we continue. Please join in, we are starting. Please join in. Please join in. आ जाओ भाई, कहाँ रह गए? See, GIT, I told na, GIT is covered in medicine also, covered in patho also. That's why I've not mentioned it here. Clear? So we'll share the one-liners of GIT which you can do. Okay, clear? So I'll try because time is the main issue. Okay, ठीक है? चलो. So let's continue. So we are discussing the GIT later. बाकी सब करा दिया है. We have covered the hernias. We have covered our abdomen, we have covered our trauma, we have covered shock, we have covered the wounds, burn, almost everything we have covered. Only thing not covered is our GIT part, and that is because I told you, because of the time issue. Otherwise it will take too much time. Okay, but don't worry, whatever we have we'll do that. Chalo, let's start with the GIT. Later we'll do the stones. Okay, first is most common type is renal stone, which is radio opaque because calcium doesn't let the radiation pass. That's why radio opaque. Yeah, they are more than sufficient for getting good score in the exam. Okay, clear? Because main target is to get a good score, is not to solve all the question. तो कभी भी नहीं होंगे, ठीक है? Then uric acid cause radiolucent. The radiation can pass. Most organic material are not good at stopping the radiation. That's why it's radiolucent. Okay. Now, how's uric acid? So we all know it is hypoxanthine to xanthine, and then we have the uric acid. Okay. That's why we give what? The allopurinol. So that's why use allopurinol to prevent the uric acid stones. Okay. So that we have discussed already in our medicine also. Next question. The struvite stone. So struvite, they are stag horns. So they look like the horn, sing of the antler. Barasinga, Hindi में होता है Barasinga. So it is a type of stag, or you can say deer, in which the horns are having multiple branching. So this branching pattern, because the stone extend to the calyces in the kidney, that's why it appear as this. Also called as triple. So याद करना, true is triple. So stru is triple and tag. Triple tag. So उसका निमोनिक की क्या है? Triple or tag. So triple tag, stag. Okay. Now what are the three things? It contains calcium, magnesium, ammonium phosphate. Calcium, magnesium. So obviously it will be radio opaque because calcium is there. So again it is radio opaque. Okay. And it is most common in female because they have short urethra. That is why very prone to risk of UTI by protease, and protease release the enzyme and urease, which will precipitate, because alkaline pH, and alkaline pH will be responsible for precipitation of calcium, magnesium, ammonium phosphate. Now comes cysteine. They are very hard. So what is this? It is radio opaque. Okay, and they are what shape? Hexagon or benzene shape, like this. So hexagonal and radio opaque is cysteine, and they are very hard also, very hard. Okay, so that's why they are difficult to break by our extra shockwave lithotripsy. Management is we give MPG, okay, or D-penicillamine. Okay, D-penicillamine can be used for the management. Okay, clear? So that is what we will do. Okay, next question. Chalo. Next question. 1 second. Okay, just replying about the tomorrow's this. Okay. Next question. Okay. Xanthine. See, right now I'm saying it is more than sufficient for NEET PG except the GIT part. All other are covered here. Okay. Chalo. Now, what is xanthine stone? So obviously it is hypoxanthine converted to xanthine. So it's again radiolucent uric acid stone, brick red in color. So brick red is this. Okay. And it show lamination. So when you, yes, do a cross section analysis, cut it, you see multiple layers lamination. We give allopurinol just as the, yes, our which stones? The uric acid stone. So uric acid stone or xanthine stone, both treatment is same. We give allopurinol. Now remember which are radiolucent. So Tixu. Tixu is what? Radiolucent, and acidic stones are CCU. So what is that? Triamptrin, indinavir, xanthine, uric acid. It create our radiolucent stones. Okay. And calcium and staghorn, phosphate, etc. It, and also very important, this one, cysteine, create the radio opaque one. So cysteine, calcium create radio opaque. In fact, this, but uric acid create radiolucent. So that is the difference. Now, what are the most common feature of stones is abdominal pain, and the radiation depend on the location. Very, very important. Mostly it could be lumbar, could be radiating downward, that all. Okay. Now, if it is upper 1/3, okay, witness the evils, that is very severe pain, labia majora in the female. Okay. Then middle 1/3, iliac fossa, hypogastrium, groin, all these are supplied by which nerve? Ilio-hypogastric nerve. And therefore, if it is on the right side, it can mimic acute appendicitis. If left side, diverticulitis. So it is mimicking diverticulitis. If lower 1/3, then it goes to the perineum scrotal area. Okay, perineal scrotal area. Okay, chalo. Now, investigation of choice in ureteric colic is non-contrast spiral CT. So non-contrast spiral. True white, they look like a coffin shape. So they look like a coffin. Okay, so coffin shape or coffin lid shape is true white. Okay, and if there is any drug they are asking for colicky pain, it's diclofenac. That is Voveron is the commercial name. IM we give. Okay, IM in this case. Okay, then investigation we do urine analysis, routine microscopic, and also culture. We can check the UTI. Now, in calcium, we see envelope shape or bipyramidal crystal. So bipyramidal crystal like this, double pyramid. This bipyramidal, can you see that? So double pyramidal. If oxalate, R glass, it is R glass shape. So R glass shape, that is R glass. Cysteine is hexene or this hexagonal benzene shape, that is the case. The red one also, and they are red, brick red. So red stones are cysteine. I discussed it here, na? So cysteine is red. This is here. So it is red color. Okay. Yeah. Brick red. Xanthine is brick red. Sorry. Xanthine is brick red. The next point, uric acid. So uric acid is irregular. So it is irregular, and rosette. Rosette is flower shape. So it is rosette shape, and needle shape is bruchite. Needle shape is bruchite. Okay. Yeah, dumbbell or yes, hourglass, dumbbell shape. This is the dumbbell shape. Okay. Chal. Next we see is 90% of the renal stones are radio opaque, but gall stones are radio because they are made by cholesterol. Okay. Then 80% of salivary are radio opaque. Again, calcium. So these two are mainly calcium based. 90% renal stones are radio opaque. So we do X-ray KUB as the initial investigation. Ultrasound is done for hydronephrosis if there is an accumulation of fluid inside the urinary system. IVP is interventional study. It is intravenous pyelography. Put the contrast and check the urinary system structure because of the dye excreted by the kidney. So hydronephrosis, proximal part obstruction, renal function, all can be given by IVP. And retrograde pyelogram is used for distal part. So for proximal we use IVP because you're giving IV, but if you are wanting to check the lower part, okay, then we are giving via ureter, and that is called as retrograde pyelogram. Okay, so retrograde is for the obstruction in the lower part, distal part. Then what are the scan? This I covered in medicine also. DMSA is for our morphology structure. Okay, it is for pyelonephritis. DTPA is for perfusion, so that is for function also. DTPA and MAC3, DTPA and MAC3, they are used for perfusion and failure. Chalo. Conservative, so ask the patient to take lots and lots of fluid, and we can acidify or alkalinize the urine depending on the type of stone. Some stones precipitate on alkaline pH, some dissolve in alkaline pH, and vice versa. Now PCNL, okay, and URS, okay, are curative in 15%. That is laparoscopic stone surgery, open stone or laparoscopic plus this are not used nowadays. Okay. Now first is our ESWL. What is that? Extra shock wave lithotripsy. It is basically we use Dornier HM. What does it basically? Yes, cracking of the stone into small pieces, okay, which are excreted in urine. So it's non-invasive. That's the benefit, is it is non-invasive. Okay, and if there's a distal obstruction, fragment will be collected into proximal part of ureter. This complication is known as the street of stone. That is lots of gravel. Gravel is what? Small pebbles or stone which are accumulating on the roadside, called as gravel. So it's the accumulation of small pieces. Okay, maximum size which we can remove is up to 2 centimeter. Okay, and ERCP, that is done in the case of gallstone. Remember ERCP, MRCP, the size is 1.5. So remember ESWL 2 centimeter, ERCP we can have 1.5. So ERCP 1.5. Bhulna nahi hai. Now hard stone which cannot be broken is BSC. BSC. So what is BSC? So Bhag SC. Bhag C. So brucite is very hard. Hydroxyapatite is what bone also contain. So bone salt is hydroxyapatite. Cysteine is very hard, and calcium oxalate monohydrate. These are very hard. So that is why they are not broken by ESWL. Which one? BSC2. So BSC2. Okay. Now what we don't do, obviously pregnancy and bleeding. It can cause more bleeding or harm the baby. That's why we are not using it. Okay. Now come PCNL. What is PCNL? Percutaneous nephrolithotomy. So we are removing the stone through access through the skin. So we are putting this a nephroscope with the ability to remove the stone. So it has the maneuverable structure which you can use to take the stone out. So this is called as our which thing? Yes, it is called as nephroscope with this. Now what is the approach? Posterior calyceal. So you come from the behind and then take the stone out. What is it used for? More than 2 centimeter or distal obstruction. Why? Because you told you in distal there could be this column of stones which can accumulate in this case. So that's why we'll use. So remember, very simple. If stone is small size or not very hard, we can use the ESWL. But if it is hard or it is proximal, then we can use this. But if it's distal or more than 2 or UTI or hard, then and also lower calyceal stone or staghorn. In this case, we can use both PCNL plus ESWL. So both can be used. MCQ. Okay. Complication is bleeding. Obviously, it's an invasive procedure. So why invasive procedure? And what can be injured? Pleura, colon, spleen. So most injured is pleura, then our colon. So very simple. If it is hard, distal or big, then we use. Yes, Monica, very good. So hard, big and distal and also UTI, then we are going for PCNL, percutaneous nephro, lithotomy. Okay. Next is URS. What is URS? It is ureteroscopy. So it is basically, complication is perforation because very sharp instrument. It is used for insertion of DJ stent or removal of ureteric stone. So what is used for? DJ stent and removal of foreign body of ureteric stone. So ureteric stone we use the URS. Okay. For renal stone, calyceal stone, we are using the either ESWL or PCNL. Now management of renal. So remember, very simple. If up to 2, we can do the ESWL. More than 2, PCNL. Hard stone, PCNL. Distal also PCNL. If staghorn, both. Sandwich technique. तो दोनों मिलके करेंगे sandwich. That is sandwich technique. So that is sandwich technique. Okay. Now comes the question, ureteric stone. If stone is up to 1 centimeter located in upper one third or middle one third, then we do ESWL better than URS. If more than one, same way, we'll go for URS. बिल्कुल similar to which funda? Similar to the PCNL funda. If stone is big but more than one. If more than one, we do the URS. Same way, more than 2 centimeter PCNL. Okay. And if any type of stone in the lower one third, again वही बात आ गई, lower है तो then URS. So remember, इसमें भी यही था, अगर distal था, hard था, so distal, hard, big size, then we are going for PCNL. Same way, if the stone is bigger than 1 or in the lower part, then we can do this. Okay, then we can do that. Yes. Now, important question. Most common organism for emphysematous cholecystitis is Clostridium perfringens, more common than E. coli. Then for emphysematous pyelonephritis, E. coli. So यहाँ उल्टा हो गया, अगर cholecystitis है तो perfringens होगा, अगर kidney है, pyelo है तो E. coli होगा, ठीक है. And most common for xanthogranulomatous pyelonephritis is Proteus, which is also causing staghorn calculi. Okay, so remember, Proteus can cause multiple problem. It is also the one causing UTI very commonly. And xanthogranulomatous cholecystitis caused by rupture of Rokitansky-Ashkoff sinus. That is for our GIT. Perinephric abscess is basically pus around the kidney in the perinephric space, and features are three, obviously: pain, tenderness, fever. So pain, tenderness, fever are feature of perinephric abscess. So which feature? Perinephric. Okay, ये रहा ना URS is ureteroscopy. Okay, ureteroscopy. It's very simple. You put the scope through the urethra, and then you go to ureter and remove the stone. That is called as ureteroscope. Okay, so ureteroscope is the instrument we are using. So ureteroscope. Okay, chalo. Next is pyelonephrosis is bag of pus, again collection of pus inside the kidney. Feature, again fever is there, anemia because you are not able to make the erythropoietin plus hemorrhage can be there, and mass in the loin area. Very important, genitourinary TB, one of the most common cause is our TB, tuberculosis. Okay, and this we have discussed already. Lungs is the most common, and these are extra pulmonary. So okay, so extra pulmonary is kidney, GIT, brain, all other area. Okay, so the two organs, kidney and prostate. Okay, chalo. So the earliest feature is increased frequency of urine, and there is sterile pyuria. So there is pus cells coming in the urine, so called as sterile pyuria. Okay, but there's no bacteria, no organism. And main thing is we see putty or cement kidney. So you will see this white opaque kidney with this lobules. This is called as a putty kidney. It's again PYQ. Putty kidney seen in TB, putty TB. Okay, चलो. So उसमें क्या होगा आपका, basically cheesy material भरा हुआ है, called as putty TB. Okay, and then kidney will later calcify, called as cement kidney. And now kidney is not working, and once is not working, it is now itself die. So that is called as autonephrectomy. That is destruction of kidney. Bladder we are discussing. Earliest change that we detected on cystoscopy, there's a TB bladder. We are discussing TB bladder. That is our uretero orifice where you see pallor. Thimble bladder. ये question आ रखा है, small contracted. Thimble is a substance which was used to wear on the thumb, and people who do suturing या क्या है वो, ladies who are doing all the work of cloth, they will wear a thimble. So thimble is to protect the thumb from injury through needle swing. So that is why it look like a very small contracted bladder, like a thimble. So thimble bladder, and the aperture become golf hole ureteric orifice. So याद करना ये किसके फीचर है, आपके TB bladder. So TB bladder is the case. TB bladder MCQ. So bladder में क्या क्या finding है, thimble bladder. Kidney में putty kidney because of again necrosis, and plus there is accumulation of caseous material. And prostate, it will become hard nodular calcified. Vas deferens show beaded appearance like this. So beaded appearance of the vas deferens with multiple discharging sinuses all along our scrotum. Sterile pyuria अगर बोला है तो you suspect our TB. Okay, clear? And IVP you can see moth eaten Yes, what thing? Moth-eaten calyx. So moth-eaten calyx, thimble, bladder, all these are word. Okay, goal, hole, ureter, all are the finding. So goal, hell, ureteric. Okay. Then investigation of diagnosis of the early changes. What are we going to do? Yes, I can't read it because this file is merged here. Okay. So what are the investigation for early changes? I think it will be ultrasound, USG, and for this is CECT, contrast intensity. Okay. So for diagnosis this, then also we can use other, like we can go for our CBNAT. Okay. Others. CVNAT. Okay, if sputum is there lung, we can have this, and you can do the analysis. Okay, chalo. Then our DST genotype test, there are multiple. Okay, ATT is there, plus complication are stricture, very common stricture, kidney failure, bladder is contracted, that's the case. Okay, so we can do what? Dilatation of the narrow structure, augmentation of the lost structure, or we can do this cystoplasty, nephrectomy, and Boris operation. Okay, Boris operation is we are connecting or we are replacing the ureter. Okay, so ureter is replaced by some gut segment, so that is called as Boris. Okay, replacement. So it is basically a graft operation. Okay, graft. Chalo. Renal tumors. First is angiomyolipoma. Okay, it's a benign tumor, lipoma. Here basically angio means vessel, myo means muscle, and fat is lipoma. So three things are there, very common females. So females have this angiomyolipoma. Usually single है, females जब भी पूछो status single ही बताती हैं और एक ही side, unilateral decision making. Okay, and it is associated with a disease called as tuberous sclerosis. Okay, where there will be multiple. Okay, what is the finding? HMB45 positive, that is your immunohistochemistry, HMB5 positive, and there could be ruptures of the aneurysm which can cause retroperitoneal hemorrhage, which is called as Wunderlich syndrome. Wunderlich syndrome. Okay, Wunderlich. Okay, investigation is CCT. Okay, and if asymptomatic, we just do observation up to 4. If more than 4, we can do partial nephrectomy or nephron sparing surgery. Then come oncocytoma. Oncocytoma, it is from oncocytes, mimic the chromophobic RCC, renal cell carcinoma. So it's renal cell carcinoma, CX. Investigation is CECT. Okay, and we see stellate scar. ये दिख रहा है आपको stellate? So satellite की तरह इसमें branches निकली है. That is the case. So that is the called as the stellate shaped scar. Okay, and if you do this also the CET, so it is when you see gross is also the stellate, and it can be seen even in the CT. Okay, as stellate. So this is a stellate shaped scar. Okay, then we discuss RCC, very important, the variants. First is clear cell, then we have papillary variant. So remember, clear cell is the most common, CC, most common is clear cell. Tumor arise from PCT, proximal tubules, and the most common gene is VHL. Okay, clear? So von Hippel-Lindau gene, and this is on chromosome 3. तो याद करना 3 है नाम, VHL 3 में होता है, and there is a deletion or translocation on the 3. Chromosome 3 with 6, 8 or 11. 6, 8, 11, 6, 8, 11. Okay, 6, 8, 11. Then come our papillary. So papillary is the one which is again from PCT, but it is the one which require hemodialysis for cystic disease. So patient kidney is not working, toxins are accumulating. So remove the toxin, we need to do hemodialysis. What is the gene? MET gene, MET. Ret gene was in which disease? Ret. It was in men. Remember men. So men 2, we had the men 2, and also men 3, we had the ret gene, RET. Chromosome number 7, ret gene was in which chromosome? Let's see how much you remember. What is our ret gene? Ret gene. Let's see how many you can remember. Ret oncogene is in which chromosome? Very good, 10. And what type of protein it code for? What was the protein involved? Very important. T से आता है. T T for tyrosine kinase. Yes, tyrosine kinase. Very good. Okay, ना ना tyrosine kinase है मौलिका. रेट का tyrosine kinase का है रिलेशनशिप जीन का, तो ये इसको बनाएगा. चलो आगे चलते हैं. मैट जीन इज 7. सो मैट क्या है? 7. ओके, मैट इज 7 एंड इट इज एसोसिएटेड विद व्हाट? यस, इट इज विद ट्राइसोमी. कौन सी? 7, 16, 17. 7, 16. And again there is samoma body which I discussed, papillary variant. So remember, papillary is samoma body which is also seen in mesothelioma, meningioma, serous cyst adenoma and our thyroid cancer. Remember, papillary thyroid cancer. Now medullary is third type. It is basically in children suffering from sickle cell trait. ये क्वेश्चन आएगा इसका. बच्चा दिया उसमें सिकल सेल ट्रेट की हिस्ट्री एनीमिया वाली प्लस मेडुलरी वेरिएंट है. ठीक है, पर अगर मोस्ट कॉमन पूछे तो क्लियर सेल है, हम ऑलरेडी कर चुके हैं. ठीक है, मोस्ट कॉमन इज क्लियर सेल. सो कौन है मोस्ट कॉमन? यस, सागरिका इज राइट. क्लियर सेल इज द मोस्ट कॉमन. ठीक है, चलो. Now comes the question. What is the most common type in the patient of cystic disease requiring hemodialysis? It was papillary. And children with sickle cell is medullary. And best prognosis chromophobe variant. Okay, children is medullary with sickle cell trait. Surgically, it is, remember, the RCC is known as hypernephroma gravids, means gravity very heavy, or radiologist or Iddanis tumor. Okay, so the surgical aspect क्या होगा? Very big tumor. Okay, चलो. Now what is the RF? Okay, RF or the risk factor is smoking, analgesic, nephropathy और cadmium और asbestos. ये कई बार पूछा है. Cadmium, asbestos can cause what? Yes, it can cause mesothelioma in the lung and can cause our, yes, renal cell carcinoma. Tried क्या है इसका? Mass is there in the, yes, abdomen. Pain is there. Hematuria. ये क्वेश्चन है. अगर hematuria pain है and mass, suspect could be cancer. Okay, could be cancer. Plus there could be cannonball metastasis in the lung. So it is metastasis in the lung. Cannonball. Okay. Now remember, tried is too late. By the time this comes, it is already done. Remember, it's hematogenous. Remember, also HCC, hepatocellular. So hepatic, yeah, hepatocellular is also hematogenous. Otherwise, most carcinoma are lymphatic, but RCC, SCC and thyroid cancer, they can spread through this. Remember, which thyroid? Which thyroid cancer can spread? Let's see if you can remember. Remember, we discussed thyroid. Which thyroid can spread through hematogenous also? Anyone? Which can spread through hematogenous also? Very good. Very, very good. Okay. Okay. Now let's move. Most common site of metastasis is lung. क्या दिखेगा? Cannonball दिखेगा. Cannonball can be seen in other conditions also whenever lungs are involved. Most common primary responsible for osteoblastic secondary in male is carcinoma prostate. क्या होगा ये? Carcinoma prostate. Okay. Most common primary responsible for osteolytic is RCC. So remember, RCC क्या करता है? Lytic करता है और prostate जो है वो ब्लास्टिक करेगा. ठीक है, चलो अगला. ये हमने देख लिया ऑलरेडी. It can cause osteolytic and vascular bony metastasis called as pulsatile secondaries, which can also be seen in follicular carcinoma of thyroid. So follicular carcinoma of thyroid. Okay. And what are the most common paraneoplastic? Increase ESR. Okay, chalo. Investigation is obviously CECT. CECT, yes, you're right, Dr. Sagarika, creating happiness, follicular. Then investigation to differentiate bland thymus from tumor is MRI. Otherwise, it is, yes, CECT. Gold investigation for IVC invasion, inferior vena cava gram. So remember, it's very serious complication. Now management is radical nephrectomy. So localized is radical. If advanced or metastatic, again radical. Clear? And what is the agent given is sunitinib. Sunitinib. So sunitinib देंगे साथ में because of the, yes, advance. Here it is hematogenous, so lymphatics are not affected. चलो. This I don't think they will ask, but still कर लेते हैं एक बार. If they are asking naming, तो RCC is rob. तो हर साल क्या होता है, आरसीबी को रॉब कर लेती है किस्मत. तो आरसीबी रॉयल चैलेंजर बैंगलोर का क्या होता है, रॉब. तो आरसीबी इज रॉब्ड एवरी ईयर फ्रॉम विनिंग देयर आईपीएल टूर्नामेंट. देन फुरमैन, सो फुरमैन, फुहरमैन, सो फुहरमैन इज आरसीसी अगेन, फुहरमैन. ओके, एवरी ईयर दे आर एफ्ड अप. एंड जैक्सन इज स्पेनिश. सो जैक का बेटा कैसे आया, पेनिस से. सो जैक का सन पेनिस. सो जैक का सन जैक. So Jack is penis and Gleason. So Gleason is prostate. So Gleason is prostate. ठीक है. So Gleason is, yes, FMGs के लिए race है. Very good. चलो. So remember these are the name of staging. Okay, चलो. Pediatric tumor. 100% exam question from this line. Most common malignancy is neuroblastoma. अगर पूछे intra-abdominal, again neuroblastoma. If eye, it is retinoblastoma ocular. Most common extracranial solid, again it is neuroblastoma. They all are neuroblastoma. Second most common is Wilms tumor. So most common is neuroblastoma. Okay. Then अगर पूछे renal, तो again Wilms tumor है. It is infancy is congenital mesoblastic nephroma. Soft tissue tumor, that is rhabdomyosarcoma. Rhabdomyosarcoma. And overall most common is ALL, which is the most common leukemia also. So the most common leukemia in the case of children, it is your AML. So ALL is the overall most common leukemia in children. Okay, overall. Okay. So children में क्या होगा, ALL होगा. और ओवरऑल भी सबसे कॉमन मैलिग्नेंसी है ये आपका. अगर सॉलिड पूछेंगे तो ब्रेन है, और ओकुलर है तो रेटिनोब्लास्टोमा. 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 चलो आगे चलते हैं. विल्म्स ट्यूमर, इट इज नेफ्रोब्लास्टोमा और द अदर नेम also called as nephroblastoma. What is the age? Very young children, 2 to 5 years. Genes are Wilms tumor 1 and 2. Okay, 1 and 2, both chromosome 11. Components are blastema, epithelium, stroma. So 3 parts are there. Best blastema, that is the tumor area, epithelium and the stroma. Now variants are 3: VAGR, Danish Drash and Backwith-Wildman syndrome. So इसके टाइप्स हैं. सबसे कॉमनली पूछेंगे क्या, VAGR. तो इसमें क्या होगा, विल्म्स ट्यूमर है. देन एनरीडिया, जेनाइटल एनोमली एंड मेंटल रिटार्डेशन. सो अगर IQ कम है, विल्म्स ट्यूमर है, एनरीडिया, दैट इज द फॉर्मेशन ऑफ डक्ट्स आर एब्सेंट, जेनाइटल एनोमली इज देयर, दैट इज योर VAGR. देन डैनिश ड्रैश, इसमें क्या होगा आपका, गोनाडल डिसजेनेसिस. ओके, सो मेल सूडो हर्माफोडिज्म. ओके, सो दैट मींस देयर इज, यस, फीचर्स ऑफ बोथ द जेंडर plus kidney failure, that is kidney failure. And Backwith was asked in the recent exam. There is hemihypertrophy, organs are enlarged, hepatomegaly, splenomegaly, plus very big tongue, hepatoblastoma and omphalocele. All together is called as Wildman. तो आपने सबको जोड़ दिया. Backwith Wildman. Wildman में क्या होगा, organ big plus omphalocele, blastoma and big tongue. That is called as Backwith Wildman. Okay, Wildman. नाउ फीचर्स क्या है इसकी भी, मास ही होगा, फीवर है और माइक्रोस्कोपिक हेमाचूरिया. इन द आरसीसी इट वाज हेमाचूरिया, नॉट माइक्रोस्कोपिक बट ग्रॉस हेमाचूरिया वाज देयर. सो दैट इज देयर. सो हेमाचूरिया इज द मोस्ट कॉमन सिम्टम. सो मास पेन हेमाचूरिया, हियर आल्सो मास पेन हेमाचूरिया, मास पेन हेमाचूरिया. ओके, पेन इसमें नहीं है. ओके, मास फीवर है. ओके, नाउ most common route, again hematogenous, it is again hematogenous and goes to lung, and we do MRI in this case, not CCT, we do MRI. CT was done for our, yes, RCC. Treatment is again our nephrectomy. Okay, and can give the chemotherapy in 5 days and radiotherapy within 10 days. Okay, that is the case. Okay. Now come ADPKD. What is that? Autosomal dominant polycystic kidney disease. Okay, here both the kidneys are replaced with multiple fluid filled cysts. You can see both the side. So these black dots are cysts. Okay, autosomal dominant, and chromosome 4 and 16 are involved, and protein is polycystin protein. So what is the feature? There is polyuria because kidney is not working well, so urine comes more. Nocturia, hematuria, nephrolithiasis. So polyuria, nocturia, hematuria, nephrolithiasis, plus hypertension is there because kidney is not working properly, hypertension. So remember, RAS is activated, which cause increased renin, angiotensin, and BP is increased. Okay. Most common cause of death is cardiovascular disorder, and the management is hemodialysis. And finally, we go for renal transplantation. It causes kidney failure, chronic kidney failure. Okay. Flea beaten is hypertension. Flea beaten is hypertension. Okay, creating happiness. Next question, investigation is CECT. Remember, cancer, all we were using CECT, but in the case of our Wilms, we were, because we need to differentiate the Wilms from which condition? Yes, so we need to differentiate the Wilms from our what? Other disorder. Then we are using our MRI. Otherwise, we are using this. So MRI to differentiate tumor thrombus, okay, is MRI. So how do you differentiate the, yes, bland thrombus from the tumor? Then we are using the MRI in this case. In case of Wilms, again we use the, yes, MRI. Okay. Next is, what is the IVP give? It gives spider leg or our cheese appearance, Swiss cheese appearance with bell or bubbles. If you see multiple bubbles, it is our IVP polycystic. Management is obviously, we have discussed, it is renal transplantation. Okay. So now question is asked, rousing sign. What is rousing sign? It is pain on right iliac fossa on pressing left iliac fossa in appendicitis. So this is called as rousing sign. Okay. Then comes our, yes, pelvic ureteric junction obstruction, PUJ. So PUJ obstruction, PUJ is mostly unilateral, most common in boys on the left. So याद करना, left है, unilateral है और boys है. So लड़कों में क्या होगा? Unilateral left side पे क्या हो गया? PUJ obstruction. तो किडनी क्या होती है? Horseshoe shape kidney. क्वेश्चन आ चुका है कई बार. Horseshoe shape kidney seen in PUJ obstruction. So PUJ obstruction. Okay. क्या होगा feature? Obviously there is accumulation of urine, so hydronephrosis, and also there is a palpable mass. Investigation DTPA. We do DTPA in this case. Treatment is pyeloplasty. So pyeloplasty is the gold standard, Anderson pyeloplasty. Then come retrocaval ureter. That is very, very important. Ureter is passing behind the inferior vena cava. It's congenital one, and it is due to the abnormal persistent of right posterior subcardinal vein. So if it persists, is okay. Which one? Yeah, it is horseshoe. Sorry, I just made a mistake. Okay, I could be. So horseshoe kidney is basically congenital disease. Yes, sorry. Okay, congenital defect. Okay, but here also it can give a horseshoe kidney. Okay, see, remember, horseshoe which is congenital is different, and horseshoe kidney which is caused by obstruction is different. So don't get confused, they are different. Okay, horseshoe. Okay, chalo. Now we'll discuss the, yes, finding. We see reverse J sign. What is seen? Reverse J. That is cobra head. Yes, you are right. That is seen in case. Okay. So now comes the question. It gave this hook-like appearance. Can you see? So this is the hook-like appearance as a fish hook. So this hook-like appearance is seen in the case of our, yes, retrocaval ureter. So retrocaval ureter. Okay. Treatment is relocation of ureteroscopy. Okay, so that is the case. अब आया horseshoe. ये congenital disease है. ठीक है, confuse मत होना. Horseshoe kidney that is seen in the case of congenital is different from the one which is seen in the case of PUJ obstruction. Okay, again it become horseshoe shape. देख रहे हो ये? So that's why it become like this. So this is again a horseshoe shaped kidney. Can you see? Okay. So confuse मत होना, ये दोनों अलग अलग हैं. Now remember what happens. The inferior mesenteric artery present at the L2 prevent the ascent of kidney, and at the level of isthmus is L3, L4. So axis is vertical. So normally kidney axis like this. Now it is vertical. Special feature is presence of, yes, calyx, medial calyx in the horseshoe shaped kidney. So calyx is there. So what calyx? Medial calyx. Medial calyx. And investigation is CT angiography. We do CT, and what do you see? We see this again, horseshoe shaped kidney like this. So horseshoe shape because of connection of the two kidneys, okay, and also called as hand joining sign, okay. Then IVP, we can see flower vase like curve of the ureter. So flower vase curve. So treatment is based on the complication. If there is a staghorn calculus, we go for PCNL. If isthmus cannot be divided, okay, so it should not be divided in the patients of horseshoe kidney, okay. This is our ureterocele cobra head, 100% exam question. So cobra head is seen in which condition? It is our ureterocele, MCQ. So cobra head, can you see this cobra head? So cobra head appearance is seen in essay, cobra is seen in ureterocele, okay. Then it is a cystic dilation, yeah, adder head or cobra head, okay. There is a cystic dilation of the terminal part of ureter, most common in female. तो याद करना female में cobra है. क्या है female में? Cobra is there in the female. Two types, intravesical in the bladder, ectopic is outside, okay. Then there could be duplication also of the ureter, double ureter. See, this is intravesical, this is duplication. So there is a duplication. Then this is the cobra head appearance. Can you see? This is the cobra head appearance. So dilated part is the terminal part called as cobra head. Next question, clinical feature, recurrent infection and hydroureteronephrosis. So that's why there is an excessive fluid. Can you see? So hydronephrosis is there in the ureter. So hydroureteronephrosis, okay. And ultrasound we can see the cyst with hydroureteronephrosis, okay. And IVP if you do can show adder head or cobra head. So remember, horseshoe, cobra head, flower vase, they are all thimble, patti, they are all exam question. They are all exam question. Management is obviously incision over the cyst wall, and then if it's ectopic type, excision and re-implantation into the bladder. So what do? You put it back so that the passage of the urine is restored. That is the case, okay. One liner याद कर लेते हैं. Most common congenital abnormality is upper urinary tract duplication of ureter is the most common. You can see duplication, 2 ureter, so it's duplication, 2 ureter here. Then most common congenital anomaly of urogenital tract is VUR, that is vesico-ureteric reflux, where infections is very common, clear, and they are autosomal dominant condition. Both are autosomal dominant. So this is the duplication here, okay. Autosomal dominant, bilateral, mostly female, okay. Cobra head, adder head, very commonly asked, please remember. Next question, two types. If there is an incomplete duplication, it's called as bifid ureter. Both ureter join together before entering into the bladder. Complete duplication, both have different opening, and upper pole is opening outside the bladder. So that is the main finding. Investigation. If upper pole ureter having ureterocele, IVP. If lower pole, we go for our MCU, that is micturating cystourethrogram. 100% exam question. MICU is done in lower pole with VUR. If it is ureterocele, IVP. Ureterocele is IVP. Now treatment. Lower pole, we go for uretrovesicoplasty, will again reconnect to the bladder, and upper pole is excision and re, very similar to what we did in the ureterocele. Remember, ureterocele we did the same thing. We did the, yes, excision and re-implantation, same as ureterocele, okay. Chalo. Next clinical feature, male में recurrent infection, okay, because of reflux, and female is continuous incontinence with dribbling of the urine but normal voiding pattern. So urine come in normal pattern that they can evacuate the bladder, but continuous dribbling is there. Very important. VUR, 100% exam question. And I told you both are autosomal dominant condition. Okay. What is there? It is very common in children. Mostly they are asymptomatic, resolve spontaneously by 5th or 6th year of age. Okay. What do you do? MCU. That is the case. Okay. And investigational choice in VUR is MCU, also posterior urethral valve and posterior urethral stricture. In all this condition, we do MCU, micturating cystourethrogram. Okay. चलो ये हो गया आपका ग्रेडिंग 1 2 3 4 5. ओके, सो 4 5 we do surgery, 4 5 we do surgery, 1 2 3 medical management, we can give antibiotics etc. Okay, chalo. Now what is the surgical? Again same, uretrovesicoplasty connected to the bladder, or sting operation is basically subureteric transurethral injection of Teflon. So we'll put the Teflon in this case, sting. अब आ गया ब्लैडर. ओके, ठीक है. मेडिको इफ रेडियोलॉजी क्लास आई विल ट्राई टू फाइंड एंड टेल यू. राइट नाउ आई डोंट हैव मच इन्फो अबाउट दैट. ओके, चलो. ब्लैडर, ectopia of the bladder. So bladder is now present outside the abdominal wall, also called as exostrophy bladder. Okay, complete ventral defect of the urogenital sinus from where the bladder etc. develop. Now question is absent infraumbilical abdominal wall. So even the wall is not developed. Okay, also the anteval of abdomen, this bladder is absent, and exposed posterior wall of bladder, and that's why urine is dribbling from the trigone. So that is the finding. Plus also we can see what all finding in male you can get. So this should be here, it's by mistake here, so I will correct it. Okay, 1 second. So remember, shallow scrotum should be here. So there is shallow scrotum because of undescended testes, epispadiasis, and female would be, yes, again it is widely separated labia. So widely separated labia. चलो आगे चलते हैं. ब्लैडर स्टोन, फर्स्ट इज माइग्रेंट स्टोन विच इज फ्रॉम किडनी एंड रीच द ब्लैडर. ओके, सो दैट इज द केस. Primary bladder is basically endemic, means local stone, most commonly in children age 2 to 4, and it is ammonia urate, and if it's urate it's again radiolucent, it's radiolucent. Okay, then secondary are elderly male with BPH or bladder occlusion, that is uric acid again. So mostly uric acid or could be struvite, so it is uric acid radiolucent, we've discussed already. X-ray show jackstone toy present in this. What are the finding? Jackstone toy present, which is made up of calcium oxalate dihydrate. Okay, yeah, it is basically bladder which is present outside its normal location, that is the case. Okay, creating happiness. Chalo, next question, clinical features of bladder. Again painful voiding, that's the main thing, painful, because as the bladder contract the stone will be touching the wall and produce the pain, that's why pain occur when you pass, and severe pain at the end of micturition, and terminal hematuria can be there with passage of 1 or 2 drop of blood, because of the bladder wall is damaged and can cause the blood to come in the end. Okay, because when you press the ureter etc. is getting the urine, when the bladder contract, as the bladder contract the stone will be pressed against the bladder wall, pain is there. Okay, here we do ultrasound, we do the ultrasound. Management for small stones is cystolithography. Okay, cystolithography, and large is EHL. Okay, or suprapubic cystolithography. This was asked in the NEET PG last year. Schistosomiasis. Okay, schistosomiasis, also called as bilharziasis. Okay, bilharziasis. What is it caused by? It's caused by our schistosomia hematobium. Hematobium. Definitive host is man, intermediate is snail. Okay, now what happens? Swimmers itch, mainly the one swimming in the river etc. Also called as Katayama fever. There's an increased frequency of micturition. Okay, very similar to GTB. that is the TB, okay, and schistosomiasis both have increased frequency and sterile pyuria as the hallmark here. So pus cells are there in the urine, that is sterile pyuria. Most common cause of bladder calcification worldwide, what is that? So the most common cause of bladder calcification worldwide is this: increase the risk of squamous cell carcinoma more than transitional cell carcinoma of bladder. Diagnosis: we can see eggs in the urine and on x-ray fetal head in pelvis appearance, okay, because of calcification. So fetal head in pelvis. Drug of choice praziquantel MCQ. Bladder rupture, very important topic, bladder rupture. So remember the story: extraperitoneal or intraperitoneal. Most are extraperitoneal. This causes the extravasation of urine. The urine comes out. So first it is RTA, which lead to pelvic fracture, and now there is an injury of the bladder outside the peritoneum, and now it is also posterior urethra. So urine cannot come out because urethra is injured. Now what are the findings? Pella, suprapubic pain, difficulty in passing the urine, and hematuria. So the finding: suprapubic pain, okay, then okay, difficulty in passing the urine and hematuria, and flame sign. This is the flame. So flame sign is there, plus teardrop bladder, like this, teardrop, and also pear shape. So these are different shape: pear, tear, flame, pear, tear, so flame, okay. Investigation is cystography, CT cystography. Contrast we are using. Management is Foley's catheter. Healing occur within few days, okay. Surgical कब करना है? Tear near the neck of bladder or repeated occlusion of catheter due to ongoing hematuria, we do surgery. Otherwise Foley's is sufficient. अब आया खतरनाक, that is intraperitoneal bladder. Why is dangerous? Because it can cause peritonitis. Urine is an irritant and contain bacterium, etc. So if it comes to the peritoneum, infection can occur, very dangerous, okay. So it occur due to external kick to full bladder. तो जैसे आपका क्या है, अल्कोहलिक है, खूब दारू पिया, ब्लैडर भरा है, उसका क्या, तो गिर गया वो किसी शार्प ऑब्जेक्ट पे जिससे उसका ब्लंट ट्रॉमा हुआ, या किसी ने लात मार दी उसके. सो इट कॉजेज द बर्स्टिंग ऑफ द ब्लैडर behind side. So again, suprapubic pain, difficulty passing, hematuria, but main is inflammation of the peritoneum, rigid abdomen, cardboard abdomen. That is the finding. Again, CT cystography, sunburst. So sunburst is seen in intraperitoneal, and tear, pear, flame is seen in intra. Okay, extraperitoneal. Intra will be sunburst. Next is management is exploratory laparotomy. We will open the abdominal wall and we will do exploratory lavage to remove all this urine and irritants and repair of the bladder defect, plus suprapubic cystotomy and Foley's catheterization. So if urine is not coming, we can make an opening above the pubis called as suprapubic cystotomy and allow the urine to drain out, okay, or if possible Foley's catheter. So that is the case, okay. Next question is cancer bladder. Again, most common is transitional. Squamous is seen in schistosomiasis, okay. If schistosomiasis, then we can see our squamous cell. If it is most common, transitional is the answer. So remember, if schistosomiasis, then it causes squamous cell, okay, schistosomiasis. Next question, transitional. What are the cause? Again, वही smoking or aniline dye. This was the exam question. Aniline dyes plus drug, which one? La phenacetin or clomifazine, cyclophosphamide, which is again used printing industry, schistosomiasis, but it mostly cause squamous cell, SCC, pelvic irradiation. Squamous cell में बताई दिया आपको सबसे कॉमन है schistosomiasis, inflammation, stones, they all, okay. Now adeno is ectopic vesicae, that is bladder outside, or patent urachus or intestinal conduct होगा वैसे ही. चलो next question, management. TCC respond to intravesical BCG, and BCG is a vaccine but it's used, so type of what? It is secondary prevention. Now this was the exam question, secondary, because if you use for treatment it becomes secondary prevention, okay. Then SCC and adeno are surgical management, they are surgical management, okay. In SCC, malignancy is nodular, invasive, we do radical cystectomy. We do radical adeno, lymph nodes are involved, mainly obturator. So we do radical cystectomy, and also we need to do pelvic lymphadenectomy. Okay, and if needed, can give our radio chemotherapy. So can give radio chemotherapy. Transitional, what are the finding? First is elderly male, smoker, age is 70, 60, 70, mainly posterolateral wall of trigone. Features are again hematuria but painless. Painless, gross, intermittent hematuria. Okay. Common route of spread is hematogenous. Remember, transitional is hematogenous. Okay. Most common site, liver, and obturator lymph nodes can be involved. It can be both, but it is involving lymph node also, hematogenous also. Investigation is cystoscopy plus biopsy, and staging is MRI. What is the staging done with MRI? Okay. Now, management. So I told you, if it is malignant cystitis, we give intravesical BCG vaccine. Then TA. So with all T, initial staging A, single low to moderate grade transurethral resection. If multiple high grade, then we are doing the TUR resection plus chemotherapy. Chemotherapy resection. T2 is same as TA. Okay, same treatment. T2 to T4 is cystectomy, chemotherapy, RT. All three. So RT, CT, and cystectomy in T2 to T2 to T4. Okay, and T2 we can do same as TA, that is T1, that is your resection plus chemotherapy. If any TN plus metastasis, then we are giving neoadjuvant chemotherapy followed by surgery or palliative care. So that's why chemotherapy is given afterwards in this case. Okay. Now systemic chemotherapy agents are MVAC. ये पूछा था कई बार. Methotrexate, vinblastine, adriamycin, cisplatin. So what are the agents? That is the case. और अगर intravesical है, MET BCG, mitomycin, apirubicin, tepa, and BCG is most effective. BCG vaccine is most effective. Now we are discussing the prostate and our seminal vesicle. First, what are the lobes of prostate? Anterior, posterior, lateral, and median. So what the lobes are? Anterior, posterior to lateral and median lobe. Now BPH is mostly in the median lobe category. So median is the one, and zone is the transitional zone. Okay. Whereas carcinoma is posterior peripheral, PP. So carcinoma is PP, posterior lobe and peripheral zone, whereas BPH is medial lobe and transitional zone. So which zone? Transitional zone. On DRE, that is digital rectal examination. Okay. Digital rectal examination. What are the zone palpated? It's peripheral zone. And lobe palpated is the posterior lobe. So remember, पीछे का ही होगा ना, PP. That's why cancer में काफी आसान है. Medial तभी होगा जब enlarge है, that is BPH. Example BPH. तो normal बंदे में you cannot palpate the median, you can only palpate the posterior lobe. Now BPH, very famous disease. Benign prostatic hyperplasia. First, it is age related. Endocrine control, which hormone? Testosterone. Plus multifactorial process is there. So this we have discussed already. Testosterone is converted to to इसको वो करो, ठीक है, 2-dihydro. It's actually should be 2-dihydro by 5-alpha reductase. Okay, इसको मैं 2 कर रहा हूँ. 2. So 2 is the main one. 2-dihydrotestosterone. Testosterone by which enzyme? 5-alpha reductase. So 5-alpha reductase. This causes the epithelium to grow, increase, and that causes the hyperplasia. That's why we can give reductase inhibitor like finasteride. Okay. Plus also we are giving drug to increase the urine flow, that is alpha blocker, prazosin. But remember, prazosin is preferred If there is what? Hypertension. Without hypertension, we use tamsulosin. So I'll give, so prazosin, it is BPH with hypertension. And if without hypertension, tamsulosin. Clear? And finasteride is used for decreasing the size. Okay, finasteride. Example, finasteride. Okay, finasteride. Image blur. Let me check. I think maybe camera issue. Let me check. Now is it okay? Sometimes the camera goes in this. Okay, it's fine. Dr. Salvation Shift. Yeah. Chal. Now next question. Clinical features. Obviously there are obstructive features. What features are there? One second. Okay. Obstructive features. That is poor flow. The stream is very weak. Hesitancy. The urine doesn't come easily. Dribbling is there. Intermittency. That is stop, continue, stop. And he feel the urine is not completely out. So these are the feature. Then irritative is fun. Fun क्या है? Frequency बढ़ जाएगा. Urgency or night time urination is there. So he has to wake up to pass the urine. So frequency, urgency and night. Frequency, urgency and night. On DRE we can see the smooth elastic enlargement. दबाओगे तो दब जाता है. It is pressable. That is the case. Plus carcinoma is hard. Carcinoma is hard. Plus we can feel a median sulcus. That is on digital examination. Now investigation is uroflowmetry, MCQ. What is the normal? It should be more than 15 ml per second. But if it is less than 10 BPH, ये question आता है. Flowmetry of urine should be more than 15. Less than 10 is indicative. And cystometry, the voiding pressure is 80, is abnormal. Normal condition voiding pressure should be less than 80. But if it is more than 80, I discussed that graph already. So this is the graph, okay, of cystometrogram. So this comes at 80. So this is what pressure? 80. This is 4. So normally the voiding occur at below 80. If it's occurring at 80, that indicate a serious problem. Okay, need very high pressure to urinate. Okay, so he need very high pressure. So that is the abnormal condition. This we have discussed already. 1A, 1B. This is 2. This is our cystometrogram. Okay. Next question. Medical management is finasteride, which I discussed. And to increase the urine flow, we can give the medical drug and surgical. Also, we give the alpha blocker, alpha 1 blocker like trazosine, prazosin, doxazosine, tamsulosin. Now, what we prefer? We prefer tamsulosin if there is no hypertension. If hypertension, we should prefer our prazosin. So the drug of choice if hypertension plus BPH. Next, we will discuss if patient has large prostate and high PSA, that is prostatic specific antigen, we can give a combination therapy. We can give a combination of alpha blocker and 5 alpha reductase inhibitors. Okay. Now surgical is TURP. TURP is the gold standard. So what is the gold standard? TURP. What is TURP is? Transurethral resection of the prostate. Okay. First, it is Nesbit technique. NESPIT. NESPIT technique. Irrigating fluid we use is the 1.5% glycine. Clear? Then bipolar we can use the normal saline. Why? Because if we are using the bipolar, what is happening? The area is small, but there's a high risk of injury. So we are using the normal saline. Okay. Most important landmark in TURP is verumontanum. So verumontanum is the landmark for TURP. Complication is retrograde. After the TURP, the ejaculation semen doesn't go forward but goes backward. Called as retrograde ejaculation. Impotence can occur in few people. Incontinence can also occur in few of the patient. Most common is bladder, neck stenosis and urethral stricture can form. Then we'll discuss the carcinoma prostate. In most common is adenocarcinoma, then transitional. Okay. But in bladder, it was transitional, more common. seen in very old people like 7th, 8th decade, mainly peripheral. We have discussed that already. Carcinoma is peripheral zone. BPH is median lobe. BPH is median lobe. Thank you to all of you for watching. It's very new thing for me because I have not done surgery for a long time and I focus mainly on medical subject like physio, patho, pharma, psychiatry, anesthesia. I'm very comfortable in this subject because I'm doing them for a long time. Surgical subject, OBG, I don't do it. I have not read, not revised. So that's why I'm not very fluent at my own way in this subject. For me, it's just like going through the motion, reading the file. But still, if you are there, it is going to be, yes, beneficial for you. At least you are seeing the important thing. Two things are there. When you yourself are driving and someone driving. So obviously when you're driving, it's something different. When someone drive you, something is different. So both have its own benefit. Like when you are doing it yourself and I am reading, that is the case. चलो अब देखते हैं इसका क्या है. एडवांस एज वही 70-80 years. हाई फैट डाइट. मोस्ट कॉमन साइट इज लंबर वर्टिब्रे. ओके, वाया बैटसन. तो याद करना, मेल क्या करता है, बैटसन. सो मेल क्या करता है, मेल बैटसन. तो मेल में आता है ना प्रोस्टेट, तो मेल में क्या होगा, बैटसन. सो मेल है बैटसन. ओके, देन मोस्ट कॉमन लिम्फ नोड इज पेल्विक. ओके, चलो, सो दैट इज पेल्विक लिम्फ नोड, ऑब्चुरेटर लिम्फ नोड ग्रुप. Investigation is TRUS, that is transurethral. We are going ultrasound. Okay, sorry, transrectal. Sorry, transrectal ultrasound. Ultrasound, guided biopsy, and investigation of choice for staging is MRI. What is the investigation? MRI is the investigation. MRI. Chalo. Thank you. I am trying my best. Okay, now tumor marker MCQ PSA. ये पूछते हैं आपसे, what is PSA? Prostate specific antigen is very commonly asked. PSA. Yeah. See, yes, it can use Batson for the bone metastasis. You are right, Avinash. Yeah. PSA. PSA normal is less than 4. If more than 20, indicative of our cancer prostate. Management, if it is tumor staging, T1A observation follow with DRE and PSA. If 1B, 1C or 2 age more than 70, then we will, yes, observation follow. If less than 70, radical prostatectomy and radiotherapy. Okay, main is prostatectomy. Okay, clear? If it is, yes, T3, T4, androgen ablation. Okay, we give androgens to ablate this, and radiotherapy is last. Why? Because 3, 4, and we can do bilateral orchidectomy, flutamide. Okay, plus we can give LH-RH agents like goserelin or leuprolide or flutamide. So these are all the agents used. Okay, last system we are discussing is penis and urethra. So these are data. Male is long because of penis is there. So 20 penile urethra. Female is short. That's why infections are very common. Urethra has two parts, anterior and posterior. Components of posterior is prostatic part, is the widest, most dilatable. Okay, and membranous is the shortest, narrowest and least dilatable. Okay, anterior is bulbar or penile. It is the longest part of urethra, especially male में, क्योंकि penis is there. Now question, narrowest part of urethra is meatus. That is the opening itself, which is more smaller than the membranous urethra. वैसे अगर देखें posterior में shortest, narrowest is membranous and meatus is even smaller than the membranous urethra. Now problems. एक कहता है epispadiasis. The meatus, the opening is where? The opening is under the penis. That is the case. So under, or if it is on the ventral surface, that is called as hypo. So hypo is under, epi is outer surface or the dorsal. So this is hypo, under, epi is outer. This is dorsal surface, this is ventral. So if it is on the dorsal surface, that is called as what? Our epi. If it is our, yes, ventral surface, it is hypo. So hypo is more common, and most common type is anterior, where is near the glands. Okay, so let's see. What are the association? Hooded prepuce, okay, hooded prepuce, okay, the covering. Then ventral chordae, ectopia meatus, flattened glans penis, meatal stenosis, microcephalus, short penis. Circumcision is contraindicated in hypospadiasis. Okay, they are all associations. Now, the best age for repair is 6 to 12 months. What is the best age? It is 6 to 12 months. Meatal advancement and glanduloplasty integrated surgery is the best. What is the management? Meatal advancement, glanduloplasty. That is, we are making the meatus go to the right place. So we are trying to make it go to the final destination, plus glanduloplasty. Okay, glans is repaired. This is called as MAGP. So the treatment MAGP is there. Complication is fistula. So complication is fistula, that can be there. Now, very common, posterior urethral valve. It's basically extending from prostatic urethra till external urinary sphincter. Okay, sphincter, spelling is wrong. Sphincter, okay. Then it is exclusively in male urethra, and most common type is type 1, which is located distally at verumontanum. Okay. Association is obviously VUR in 50% of the cases. So remember, urethral valve is very common with vesico-uretary reflux. Infections are there, but most respond, they resolve. Now, there is a oligohydroamnios, less urine and also less amniotic. Why? Because if there is a posterior urethral valve, the urine cannot come. Okay, and what is the result? The urine is less, so amniotic fluid is formed. So less formation of amniotic fluid. Why? Fetus urinate to make amniotic fluid. Because of this VOR, the urine cannot come out. That's why oligohydroamnios is there. Plus, lungs are not developed properly. Pulmonary hypoplasia, renal parenchymal dysplasia also there, plus bladder dysfunction. Clinical feature, MCQ, hydroureteronephrosis, bilateral, because urine is not coming. So both the side are dilated, both side because urine is not coming. Bilateral palpable abdominal mass and distended bladder. Urinary ascites. So ascites is there, which is due to excessive urine. And we do again, all the lower part we do this micturating cystourethrogram. And what is the prenatal keyhole sign? What is the keyhole? We all know how is the keyhole. This is a keyhole. So keyhole appearance is seen on the ultrasound. So ultrasound show keyhole appearance. दिख रहा है आपको ये? This is keyhole. Keyhole, MCQ. So keyhole appearance seen in posterior urethral valve, MCQ. Yeah, I don't know what is happening to this. Okay, let me remove this. Okay, now it will not change. I remove this autofocus. What happened is autofocus. So when I sometimes move my head, it blurs, is not able to focus. Now phimosis. What is phimosis? It is basically most common causes poor hygiene. Like you don't clean the glands properly by withdrawing the prepuce. What happens? It can lead to our infection, and then it cause the the glands not getting exposed. You cannot withdraw the foreskin, and that is called as our phimosis. What is the problem? Difficulty in micturition, even erection is difficult. So in children there is a ballooning of prepuce because the urine cannot come out. So it causes a expansion like a balloon. Okay, during maturation. Adult, it is difficulty intercourse. Why? Because when erection occurs, the glands comes out. Now glands cannot come out, so that's why it causes difficulty in intercourse and also maturation. Then complication, it could be calculus formation because of accumulation of all, plus inflammation of the glands called as balanocytis and increase cancer penis risk. That's why we should do what? The treatment as soon as possible. So in children, we can give steroidal cream, okay, 4 to 6 weeks, or we can do circumcision. Even if after steroid no management response, then we can go for our surgery. Okay, so what are the indication? Age, which is nearing the intercourse age, plus there is recurrent infection and no improvement after steroidal cream. Then come para, it's the reverse. Once the prepuce has retracted, it cannot be brought back. So again, it is seen, okay, after catheterization, so it's acquired. So that's why it is acquired. Okay. Then this question is, remember, urethral injury. Remember, if there's a posterior urethral, the main thing is road traffic accident, the main finding. If it's the most common site, it is membranous urethra. And what is the finding? It is urine retention, blood and blood at the meatus. ये आपसे क्वेश्चन आता है, अगर कभी एग्जाम में आया blood at the meatus plus urine is not coming out and pelvic hematoma, suspect our urethral injury. Remember, urethral injury, urine will not come out plus blood is seen at the meatus. Okay, that's the case. Important information, if anterior, again similar finding, there is urethral injury, urine retention, blood at the meatus and superficial perineal hematoma. Here it was pelvic hematoma. So remember, if posterior, where will the blood accumulate? In the pelvis. If it is anterior, blood is in perineum. So that's why you can differentiate by checking where is the blood accumulating. We can do an ultrasound to check. Management is suprapubic cystotomy to let the urine drain out. So that is, we make a opening above the pelvis in the bladder and put a tube and let the urine drain out. That is called a suprapubic cystotomy. Later we do a delayed repair within 3 months. Okay. Anterior, I told you already, it will cause, again simple thing, anterior causes what? Blood in the perineum or the pelvis. Yes, आगे तो perineum है ना, तो perineum में होगा. पीछे क्या है? पीछे है आपका pelvic area. So that's why blood in pelvic. So pelvic hematoma. What is the, yes, injury? It is external kick which can also cause bladder bursting and cause the, yes, bladder injury or stutter injury. Like कोई गिर गया पाइप पे या मेन होल पे तो उसका नीचे से आया, so that force from the below, that is perineum area, causes anterior urethral injury. Okay. Clinical feature main वही है, blood at meatus is the question they always ask you. Okay. Management is वही, suprapubic cystotomy, then delayed repair. Stricture can be there in case of trauma or infections also. Infections can cause strictures. Then investigation is, again remember, posterior urethral stricture is MCU, anterior है तो RGU. तो क्या करोगे इसमें? RGU. और अगर दोनों करना है तो RGU plus MCU, RGU plus MCU. Okay. So retrograde कर सकते हैं या फिर micturating कर सकते हैं. That's the case. Can you see? This is penile urethra and this is showing the stricture. This is the bladder. All we can visualize. Okay, with the tip of the penis. Now, for the treatment, dilatation is always done in case of stricture. Okay, we can even do urethrotomy to open this. Okay, and if there's a very long stricture, excision. So if very long, excision, more than 2, then excision reconstruction. So remember, छोटा मोटा है तो dilate करो. If small, dilate, or we can do urethrotomy. There is opening of the this urethra for the stricture. If it is long one, then we have to excise the stricture area, and if there is more than 2, reconstruction is also needed. What is the tissue we take for transfer? Buccal mucosa. So we use the buccal mucosa for repair. Then come our, yes, Peyronie's disease. What is this Peyronie's disease? It is basically vasculitis of tunica albuginea, which causes plaque over the dorsal aspect of the penis. This plaque on the dorsal aspect causes the upward curvature of penis. So what is the upward curvature of penis? Upward, up. So ये क्या है? Peyronie. So Peyronie क्या है? ऊपर उठ जाती है. Peyronie में ऊपर उठ जाती है. तो क्या है? पेनिस ऊपर उठ गई. So ऊपर उठी हुई पेनिस को क्या बोलते हैं? Peyronie. क्या बोलते हैं? Peyronie's disease. Peyronie's. Okay. So क्या होगा इसमें? Importance हो जाएगा. Painful erection because obviously there is a vasculitis of the tunica albuginea. And finally, triad क्या है इसका? Galeazia triad. So DPR क्या है? DPR deep contracture, Peyronie's disease and retroperitoneal fibrosis. So 3 features are deep uterine contraction, Peyronie's disease and retroperitoneal fibrosis. क्या बोलते हैं? Galeazia. Galeazia. Treatment ज्यादातर resolve or we can do N bits operation. Okay, so I think in this they will remove this plaque and yes, restore the structure. Now carcinoma penis. Most common, remember, skin है तो squamous ही होगा. So squamous cell carcinoma, mainly lower people, and it is related to phimosis. Phimosis is poor hygiene. Again, lower class people, they have poor hygiene, poor, environmental areas like hygiene is not poor, they don't change the undergarments also, this. Then neonatal circumcision is protective in this case. Okay, what is the virus? Why 16, 18, 31, also for cervical cancer. Pre-malignant condition is very important, that is Buschke-Lowenstein tumor, also called as verrucous cancer. So verrucous cancer. Okay, now what is the cancer in situ in the penis is Bowen disease. So it's not invading basement membrane, called as Bowen's disease. Also glans is arthroplasia of Queyrat. Okay, and most common site is glans. Most common is glans, then prepuce, then sulcus. So what is the area? Glans area, then the skin covering, that is prepuce, and the sulcus, this is the sulcus. So these are the three sites: glans, prepuce, sulcus. GPS. So mnemonic है GPS. चलो, clinical feature is foul smelling discharge, lesion, ulcer is there. So mostly ulcers are there, could be growth, ulcer or growth. Sometimes there could be growth or ulcer. Okay, could be sometime. If HPV, we can see even warts. Okay, and lymph node are inguinal lymph nodes. Okay, so that's why if a patient ever come with inguinal lymphadenopathy, give antibiotics. Remember, bubo can also be there, so we always give. Okay, chalo. Now one-liners. Most common cause of death in this page is due to the erosion of femoral vessel, which cause the bleeding. Second most is sepsis, infection is there. Then most common route is hematogenous here. Site is lung. Okay, we do biopsy for this. Obviously most of the carcinoma biopsy is preferred. Staging we use MRI, and sentinel biopsy is Cabana procedure. Cabana. तो क्या हो गया इसका? पेनिस का कबाड़ा हो गया, Cabana. Can you see the skin is so red at the meatus, plus erosion of the, yes, mucus is there, mucous membranes, that is there. Okay, management. If prepuce circumcision, remove the circumcision of the prepuce foreskin. If distal part, we do partial penectomy with 2 centimeter margin. If it is proximal part, total penectomy with perineal urostomy. So we make a opening in the perineum for urine to pass, and we do total penectomy. गया ये, अब ये समझ रहे हो, इसका हो गया कांड. That's why please don't let the cancer, yes, affect your penis. ठीक है, because in a male your penis is your main guiding principle. तो आपका पेनिस ही चला गया तो बहुत ही बुरा हो जाएगा. पर आजकल क्या है, they can create actually a artificial penis and they can put it. So आजकल क्या है, they can create artificial, like a female want to become male, होता है gender क्या बोलते हैं आपका, reassignment surgery. तो उसमें क्या कर सकते हैं, male become female, female become male. So that is the case, but again it's not good. And what the agent use? Cisplatin or bleomycin. अब आ गया आपका testes and scrotum. First, undescended testes. At birth 3%, at 1 year 1, because most of the undescended, they can go back to the scrotum by the age of 1 year. Okay, spontaneous descent is up to 3 months of age. Okay, and undescended is two type. One is inguinal or palpable, which can be palpable in the inguinal canal area, or if it is intra-abdominal, it will not be palpable. So palpable is good, that means it is in the canal, can reach. Abdominal is bad because different. And with the finding, the Leydig cell which make the testosterone, they undergo hypoplasia, and that's why very bad problem. Okay, now remember साथी, इसकी क्या है complication? साथी हाथ बढ़ाना, इसका हाथ नहीं बढ़ेगा, कुछ और बढ़ेगा. पहला sterility, so cannot make semen. Atrophy of the testes is there. Then trauma, tumor, torsion can occur. Okay, so trauma, then tumor and torsion of the penis, this testes. Then hernia, because the processus vaginalis is open. So that is the case. So processus vaginalis is open. So it allow the passage. So it's patent. So patent processus vaginalis, inflammation. So साथ ही है इसका, ठीक है. So a person with undescended, we can do orchidopexy. Okay, and it decrease the risk but also facilitate the early detection. What is the tumor in case of this? Seminoma. LDH is the tumor marker for seminoma. Investigation is inguinal exploration. And what is diagnosis of non-palpable abdominal? Laparoscopy. What do you do? Then we do what? Perform laparoscopy. If non-palpable, laparoscopy. If palpable, we can do our inguinal exploration. Now during this, follow testicular artery and vas deferens to reach up to the testes. Okay, if vas deferens is blind, it doesn't go anywhere, and then testes may not be present. If testicular artery, then it is agenesis. There is no point. Why? Because without blood, no function. No blood, no growth, no function. So necrosis will occur. So ultimately, agenesis, necrosis will occur. No need to recover this organ. If artery is blocked, it is not going end of the artery. That means the testis is already dysfunctional. So no function, necrosis is there. Okay. I'll tell you. So have a look. Okay, Dr. Prasanna Dash. So best age for this is 6 months. Should not be delayed more than 12, then atrophy will occur. So 6 months is the age we should do orchidopexy. And if it is, yes, delayed more than 12, then it's not good. That's why what is the age? 6 to 12 months. What is the age? Is 6 to 12. And what is the best result? Is microvascular testicular auto transplantation. Give the best results. Ectopic testis. So let's see what is that. It is normal descent till inguinal canal. Then वो भटक गई. Ectopic क्या है? कहीं और चली गई. Undescended मतलब अटका हुआ है, जा ही नहीं रहा आगे, जबकि कहीं और चली गई. वो क्या आपका? Ectopic. Ectopic is कहीं और चला गया. ठीक है. So testis is in abnormal location is ectopic. Testis is not going further. Traffic jam. So traffic jam is undescended and going anywhere. रास्ता भटक गया था. Google Map. Google Map sometime you want to go to some area, it make you go somewhere else. Okay, इसे क्या बोलते हैं? इसे कहते हैं आपका yes ectopic. What is the most common location? Superficial inguinal pouch is the most common. Least common is contralateral scrotum. What is the least common? Least common is our contralateral scrotum is the least common. Okay, most common is inguinal pouch. Okay, here the testis is normally developed palpable. So what do you do? Orchidopexy. So that is orchidopexy is done. Best age I told you 6 months, should not be delayed more than 2. Best is 1 year. So ideally it should be 1 year. Okay. Then come inflammation called as epidermolysis. What happens? The most common if sexually active, chlamydia. In elderly, children, homosexual, E. coli. Why? It come from gut. So homosexual do anal sex. So anal sex, E. coli in the gut feces will enter and cause the infection. तो याद करना, ज़्यादा anal sex करोगे तो you can get E. coli into your penis and cause inflammation of the testes, epidermis, etc. इसमें क्या है आपका? Prehensile sign is positive. Cremasteric reflex is positive. What is cremasteric? If you stroke the medial side of thigh, the testes is lifted up. So what happens? Testes lifted upward. On stroking medial side of thigh. This is called as our what? Cremasteric reflex. Plus thickened cord is there because of inflammation. Okay. Investigation of choice for diagnosis is ultrasound, thickened cord, or hydrocele can be there. Management is NSAIDs and antibiotics. Then come our testicular torsion, could be intravaginal, that is in the process vaginalis, or could be extravaginal. Okay. Now, if it is intravaginal, it is bell clapper deformity. Okay, bell clap. So testis is hanging like a clapper in the bell. So have you seen the bell, मंदिर का घंटा? That is why it is torsion. So that's why it's free. So rotate. जैसे आपने free छोड़ा है ना, तो घूम जाता है. तो कई बार होता नहीं आपका, when you play with something, your mobile phone cord, so it hang and rotate because it is free. So that is bell clapper deformity. Okay, and it is intravaginal one. So seen in younger patients. Okay, bell clapper. This is bell clapper. So it is hanging free like this. So that's why it rotate. And what is the find? Damming sign. The affected testis is much higher. So there are two testes. Normally they should be same. But if it's a torsion, घूम गई है, तो थोड़ा ऊपर चढ़ जाती है because of this. Then angel sign. What is this angel sign? Angle sign is contralateral testis is normal lying and the affected one is high riding. Prehensign is negative, cremestric is negative. They are seen in inflammation. They are seen in, yes, orchitis. Orchitis. Investigation will do Doppler to see. So Doppler is there. So that is the case. This is torsion. So torsion is, there is a rotation of the testes. So the spermatic cord and vessels, it are now entangled. Next question. It's an emergency orchidopaxy within 4 hours, else ischemia, necrosis will occur. If ischemia, again we do orchidectomy. We'll open and then correct it. So orchidectomy is done in the case of ischemia. During orchidectomy, contralateral scrotum should be explored. And it is a bell clapper. Again we do bilateral because it's better to be, yes, क्या बोलते, preventive assurance other than just findings. Okay. Hydrocele is basically collection of fluid between testes and tunica vaginalis, TT. So testes or tunica vaginalis. Most common is vaginal hydrocele, where the fluid is in the case. So this is the case. So processes, vaginalis is patent, fluid accumulate there. Now types of hydrocele. One is congenital, patent, this vaginal processes, so fluid will accumulate. Normally there is a obliteration by 2 years, but if it doesn't obliterate, the fluid will accumulate. Management is herniatomy. Now primary vaginal hydrocele is the most common type overall. It is very tense. Testes is completely surrounded by fluid, and we do a trans illumination test with a torch. What do? We put a torch under the, yes, this swelling, and you can see the red glow all out because the fluid allow the light to pass. That's why I see a red glow. That is case. But in case of hernia, it is absent. Absent in hernia because the structure of hernia are more solid, opaque, they block. Absent in hernia. Next is secondary vaginal hydrocele. It is basically after TT, trauma, tumor, or this epidermoorchitis, where you see cord hardening is also there. Okay, so that is secondary hydrocele. Primary is patent processes vaginalis. Secondary is inflammation, trauma, or this tumor. Management. If small, lord plication, और जब बड़े साइज का हो, जबोलीस, जबोलीस, और वेरी बिग एक्सीजन, तो एक्स बहुत बड़ी वाली या बड़े वाला होता है. सो अगर याद करना छोटा है, एक बार याद कर लेते हैं. कैन यू टेल मी फर्स्ट प्राइमरी का कॉज क्या है? प्राइमरी का कॉज क्या होगा? प्राइमरी, व्हाट इज द कॉज ऑफ प्राइमरी? एनीवन? प्राइमरी. सो कॉज ऑफ प्राइमरी विल बी व्हाट? प्राइमरी इज पेटेंट प्रोसेसेस वेजिनालिस. Secondary is trauma, tumor, infection. Treatment: small, medium and large. तो क्या करना है small में? What do you do in small? Anyone? What will you do in the case of small? Tell me. So what are we going to do in the case of the small? What are we going to do? Tell me. So if there is a small one, what are we going to do? Yes, if it is a small one, we are going to do which procedure, which thing? Yes, lords. If medium, जबोले, जब we met जबोले, और large है तो excision. So X बड़ी वाली थी तो large में excision. Large is excision. Large is excision. Very good. Varicocele. Remember, it's a dilated, tortuous, pamniform plexus of veins, and it is located posterior above the testes. So above the testes, and it give you a worm-like sensation. So give you a worm-like sensation. And remember, okay, most common on left side because the gonadal vein drain to at right angle to left renal vein. That is nutcracker phenomenon. That is a nutcracker phenomenon. Clear? Next is, this is the varicocele, dilated pamniform plexus. Patient come with swelling and discomfort on the scrotal region. So discomfort where? On the scrotal region. Swelling become more prominent on standing and it decompress on lying down. तो खड़े होगे तो ज्यादा होगा, ग्रेविटी से लेट होगे तो why? Because of gravity. नेक्स्ट एडवांस स्टेज, बैग ऑफ वर्म, देयर इज अ क्वेश्चन, बैग ऑफ वर्म आया, सस्पेक्ट अवर वेरिकोसील, ओके. Finally, suspicious varicocele. In patient of vascular invasion, there could be again varicocele because of blockade of renal vein. So again, veins get dilated. Okay. Feature short history, seen in elderly, suspect some cancer. Okay, and doesn't decrease on lying down. If it is a varicocele because of the dilation of pemphiform plexus, then it will cause what? It will cause a decrease on lying down. Okay. Investigation, Doppler, but best is venography. So we will see the veins by putting dye venography. Okay. Management is high inguinal ligation of pemphiform plexus near the deep ring, or Palomo operation where we do ligation of the gonadal vein, or microvascular subinguinal ligation of pemphiform plexus, that is also there. Now come this question came, photo came, direct photo, Fournier's gangrene. This photo itself came. Photo was there. What is that? It is our idiopathic scrotal gangrene. Okay, it is basically polymicrobial infection, aerob, anaerob, involving the skin, fascia, deep fascia. That's why there is a structure which are affected are mainly skin, outer structure. What is spared is inner structures are spared, like Carpora cavernosa, so erection can occur. Spongy bodies are also spared. Urethra, testis, quad. So inner structures are spared, mainly the outer structures are affected. So severe pain plus blackish discoloration of perineum, fever because of infection, systemic toxicity can occur because of inflammatory response, and there's a very bad fetid decaying smell with dishwater discharge. Okay, management is surgical debridement and skin grafting. Okay, finally tumor marker. यार वॉइस का अभी मैं कुछ नहीं कर सकता, इसकी ना बैटरी कम है, आई फॉरगॉट, टुमारो आई विल गेट द बैटरी करेक्टेड. ओके, सो ट्यूमर मार्कर AFB इज रेज्ड इन यॉर्क सैक ट्यूमर, embryonal carcinoma and teratoma. So these are the three: yolk sac, embryonal carcinoma and teratoma. It is increased. SCG increase in choriocarcinoma, which is syncytial trophoblast, embryonal carcinoma and seminoma. Other marker again LDH is for our seminoma, PLAP and GGT. Okay, one liner. So most common renal stone is calcium oxalate, which is opaque. Radiolucent is uric acid. Secondary bladder is uric acid, more common than struvite. Primary bladder stone is ammonium urate, and prostatic is calcium phosphate. Pancreatic is calcium carbonate. Salivary gland is again calcium. All three are calcium. So calcium stones, and most common gallstone is cholesterol, which is a pigment stone. So with this, we'll finish this session. So I've covered all except the GIT part. Half the GIT I will cover in pathology. You can do the pathology one. I'll cover. Plus my medicine is the case. Chalo. So I did my level best because time का भी तो issue है ना, मैं कितना कराऊँ. I'm taking class since morning 9 AM. I take online batch, offline batch, our NLC. Then I take your session. Plus I have to go traveling for classes for PG. Then I have to go to NEET PG, Lucknow. So very hectic. I know how I am managing all. It's very hectic, very tiring. 19 subject doing 3 times. Online, offline, YouTube is very difficult. And that too time is but just 20-30 day. So I'm working almost 12 hour daily, 12 plus. सुबह 9 से अभी 11 बज गए. कितने हो गए? Almost 14 hours. So very difficult, but again, I am doing my level best. Even if one student get benefited, it's very good. If 10, very, very good. So we don't care. Okay, we only focus on our efforts, not on the outcome, because outcome हमारे हाथ में है ही नहीं. It is not in our hand to check the outcome. We can only make efforts. Okay, that's the case. Okay, चलो. Tomorrow I will again post after checking my schedule. वही टाइम होगा 8, 7 और 8. So we'll start. चलो, take care. Bye bye. अभी तो मुझे ऑप्था के क्वेश्चन बनाने हैं because there is a question discussion, so it's not easy. So I'll do that. Take care. Bye bye. I'll update the time. It'll be 7 or 8. I'll update. Okay, चलो. Take care. Bye bye. क्या बात है. Thank you, Dr. Prasanna Dash. Congratulations. Keep working hard and best of luck for your NEET PG. Best wishes to you. Very, very, very thank you.